एसी तो चला। Good evening, everyone, and a warm welcome. Hope you all are doing well and safe. I am Dr. Nitin Sharma, Head and Neck Surgeon at HCG Cancer Center, Ahmedabad. Today, I have privilege to be your host, and I welcome you all on the behalf of entire team of Oncosurgery Master Course 6. Webinars like COVID has become new normal, mostly dealing with theoretical topics. To break this chain this time, in this sixth edition of Oncosurgery Master Course, we have decided to take a separate path to host a confession series, the lesser known path of exploring the complication in head and neck surgery. As expected, the registration numbers have already hit 1,500 plus, and still we are counting. We have very good enthusiastic participation from all over the world. This has become possible by the committed effort of the fantastic team Oncosurgery Master Course 6 that I am going to introduce to you. This Oncosurgery Master Course series took off before 6 years with the vision of Dr. Kaustup Patel and Dr. Rajendra Toprani, and they are beacons whose light shines bright over event as the organizing chairman. The course is conceptualized by course directors Dr. Dushyant Mandlik and Dr. Dakshesh Patel, the clockwork and precision management by organizing secretaries Dr. Parin Patel and Dr. Aditya Joshipura. The science of the event, our wonderful scientific committee, Dr. Purvi Patel, myself, Dr. Nitin Sharma, Dr. Dhanush Gohil, Dr. Ashay Shah, and Dr. Mitesh Patel. For design, conceptualization, and coordination, we thank Mr. Sanjeev Dhawan, the man of ideas from Ahmedabad Cancer Foundation. Friends, let me explain some rules of the engagement. In order to conduct the smooth session, where the views of the dignitaries are heard, the attendees will be muted. All questions are to be posted in the chat group, out of which the relevant ones will be forwarded to moderator or speaker, and the questions will be answered. There will be 2 lectures by senior faculties, which will be followed by an expert panel discussion moderated by the master. So friends, we have ample amount of time. You can ask as many as questions you want, and everyone will be answered. We expect your patience. Friend, this is a series of 6 Saturdays taking up one subspecialty of head and neck each time, out of which this is the 5th episode. Now I will hand over the program to my colleague Dr. Ashay. Dr. Ashay will introduce to you with faculties. Dr. Ashay.
Yes, thank you very much, Dr. Nitin Sharma. A very good evening to everyone. I'm Dr. Ashay Shah. I'm a head and neck cancer surgeon in HCG Cancer Center, Ahmedabad. And once again, I welcome you all on behalf of Team OM 6.0. So today we'll be dealing with the complications associated with the surgery that has widened the horizons of head and neck resection and improved functional and cosmetic outcomes. And that's why complications can have huge impact on the overall quality of life of patients as well as doctors. So to open our session, we have veteran of the field, Dr. Sandeep Mehta with us. He is a plastic and reconstructive surgeon who is associated with many apex institutes of India, and he has performed more than 15,000 cancer reconstructive surgeries. He has done pioneer work with super microsurgery in preemptive lymphovenous anastomosis for prevention of lymphedema. So we are delighted to kick off our session of OM 6. So to Sandeep sir.
Sandeep, your voice is muted.
I think we need to be muted. Okay. Am I audible now?
Yes, sir.
Yes,
You're
sir.
audible, sir.
Thank you, Dr. Nitin and Dr. Ashay, and thank you, Dr. Kaustup, for making it possible to me to be here with you all. And I think we can start the session. Maybe allowed to have the screen sharing, please. I would be actually dealing with complications in the local and the regional flaps. And to that effect, it will be something of more value in the present COVID era, where long surgeries seem to be a little off the beat. When we talk about complications, we need to have a very clear-cut definition about them. It's a secondary disease or condition which aggravates the already existing one. And so when we are dealing with complication, we are not only dealing the technical aspect of it, but also we need to do a lot of dealing with the patient and the family, which most of us learn with time and has to have more of a human face than the technical skills they demand. The common complications that come across any surgery, the hematomas, the bleeding, infection, seroma, and delayed wound healing is also part of the reconstruction. But specifically when reconstruction is added to the head and neck surgery, it's the flap failure which comes to the fore. And when there is a flap failure, the most common thing that comes to the mind is a fistula formation, a delayed wound healing, which delays a adjuvant therapy, which increases the chances of recurrence, and finally leads to a poor functional outcome and a poor quality life. Rare circumstances would be when the flap failure leads to death because of secondary hemorrhage or a carotid blowout. I would be dealing with certain key flaps which are commonly used as the regional and local flaps, PMC being the regional one, and the local flaps would be either forehead, temporalis, nasolabial, the submental, and the subclavicular, supraclavicular. Something which is very common to all the flaps, and especially the pedicle ones, it applies to universally in the foreground, that whenever we choose a flap, we need to see that it's of the appropriate size restricted to its vascular territory. It's like a demand of a site of reconstruction does not actually increases the size of the flap at that point of time. The common philosophy that is there whenever we are handling a tissue which has to be transferred is that you treat it like a baby. So you have to avoid sharp bends or kinks, see that it is well relaxed, and there should be no pressure on the pedicle when you are actually doing the dressings. The suture should be tension free. And whenever you find any seromas or hematomas, see that in the area where it is very relevant, especially around the pedicle, if we can really evacuate them as early as possible. And there is a very typical aspect of pedicle flaps that they would not seem to be failing in the initial days. First 3 to 5 days, they would almost look normal, but then things start failing out. And then we have to be wary about that these flaps can even fail later on. Coming on to the pectoralis major myocardial flap, is one of the hardiest, the workhorse, because of its constant vascular anatomy. It has a good reach to the oropharyngeal defects. It has technically easy to raise, and almost everybody masters it well. It consumes less time and provides a good muscle to the neck as well, so that it covers not only the cavity to which it is reaching for reconstruction, but also covers the neck where it is passing through. And we can have a large flap for both intraoral and extraoral covers. But then there are certain disadvantages, that it is bulky. It needs meticulous planning. This is something which I'll be highlighting later on. And definitely in the females, it is difficult and adds to little more complications. There are certain other less important complications like hair growth and a band formation in the neck, which can also be dealt with. When we talk about complications for pectoralis major, there are large number of studies with very widely varying figures, because the complications that they collaborate together would be as minor as a suture dehiscence. But still, I will go through certain key articles and the key studies that have been published in the initial period, which spanned almost similar number of cases. The complication rate in them ranged from 40 to 63%, but only 1/4 of them, that is only 26% of the whole cases, required any revisional procedures. The first and foremost of them is a study from Tata Memorial in the year 1996, where the flaps were studied over a period of a year between 1990 and 1991. Total number of flaps were around 220, and the overall complication rate was 40.5%. The most common of them which came out to be was a flap necrosis, that was around 27.3%, and mostly so the partial, and total necrosis only took place in 2.7% cases. Fistula happened in 12.7%, dehiscence was around 15%, and 20% had infection. The hematoma at the donor site was around 2.5%, whereas in the neck was around 2%. And mind you, 40% of these on exploration were negative for any active bleeders. Coming to another surgery, almost at the same time with similar number of flaps, was from the MSKC Center, New York. And this also had around 214 flaps in 211 cases, but this was a study staged over 10-year period. And they had a flap necrosis rate of around 32% with a fistula of around 29% and almost similar other parameters. But when we look at the larger picture of this whole issue, we find that even smaller incidence of any disruption comes as an indication of a complication with the flap. Whereas if we look into the overall management of these complications, more than 80% would not require any active management. The risks which are associated, which lead to complications is pectoralis major flaps. Mostly it is the female sex, age of about 70. And especially so when the reconstruction is being done for major glossectomies and for hypopharyngeal defects, whether they are tubed or even as a patch. Following radiation, chemotherapy, and any resurgery, the risk also is higher. And the complications definitely added with the obesity and diabetes with hypertension having at its severity. Whenever a bipedal flap is raised, there is always increased risk of complications. Coming to management, as a nutshell, as I already said, more than 70 to 80% would be dealt with conservatively. Only 1/4 of them would require any surgical intervention, which would be in the form of minimal debridement, secondary suturing, evacuation of hematoma, and at the most skin grafting, because most of the time, not all the components of the flap are lost, and one may get away with just doing skin grafting of the left tissue where the granulation tissues appear. Second flap is very rarely required, hardly in 2 to 3% cases. When we look at the management of complications, one looks at necrosis, which is in the marginal areas, distal edges, and limited to an extraoral component of a double flap. The best strategy is to wait and watch. And this should at least stretch for 2 to 3 weeks, because most of the time we find that the congestion that is seen in the earlier phases just clears out over a period of time. That is the inherent microcirculation of the flap which gets adjusted to the ischemia that has taken place. So we should not hurry up in doing any debridement for such cases where there is no risk of exposure to any inner vital structure or any implant. But when we see that there is an intraoral necrosis, but there is an intact suture line, there is no salivary leak in the neck, drains are clear, still do not debride immediately. One has to have a little more patience with that. Just do a support contour bandage, see that the neck flaps adhere very well, and the risk of contamination from the oral cavity, even if it has a micro leak from the suture line because it is having necrosis, would be minimized. Other thing is when we have a, can I have the screen limited to this? Okay. But when definitely we have a dehiscence at the suture line, we should, and the flaps are viable, we should go ahead and do the suturing as soon as possible. One should not wait any more time for that. A stitch in time saves 9. The most dreaded of the complication is when we have a necrosis in the oral cavity and dehiscence and salivary leak in the neck. And that's an orocutaneous fistula or a pharyngocutaneous fistula. The immediate action should be to facilitate the drainage from the neck wound. See that the skin opening is large enough. We can either replace the tube drain with a corrugated drain or start doing the packing with the Vaseline gauze 2 to 3 times a day so that nothing gets collected inside. Debride the tissue very conservatively, but if you find that any vascular tissue is getting exposed, best thing is to plan a flap immediately and let the patient be on RT feed for longer time. These are certain tips when we are doing a preemptive cover for a laryngeal closure, which is a post-salvage laryngectomy, and we need to use a pectoralis major muscle to cover it. Ideally, we just cover the area which has been closed with the muscle But I would like to add certain points here is where we need to do a tacking of the sutures from the prevertebral fascia to the undersurface of the muscle, almost isolating the whole muscle, isolating the whole repair from the carotids in the lateral aspect. At the same time, also make a point of attaching the muscles at the supramohyoid group of muscles so that this flap stays in place. The basic premise for enhancing the reliability of the pec major flap is to do a proper planning. And for that, any plastic surgeon would always advise a reverse planning. Reverse planning means that the fulcrum of your flap, which is a pedicle flap, should be very well planned so that it reaches the defect in a most relaxed manner. To that, I would say that even today, one should not find it I would say it should not be coming to someone's disgrace that if we have to do all these plannings in every bit of the case, because there are certain minuter points which come to light when we do these kinds of maneuver. Here we see that the flap lie has changed almost by 90 degrees, or else we would have taken the flap longitudinally. Otherwise, this is 90 degrees at angulation to the pedicle. Whenever we raise pedicle flaps, whenever we are raising the pec major flap, I would suggest to divide the clavicular head, which increases its reach so that the pedicle remains relaxed. The deltoid and the acromial branches of the thoracoacromial axis should always be ligated. It not only increases the reach of the flap, but also enhances the supply to the pectoral branch. The denervation of the nerve which is supplying the pedicle adds to the auto-regulation of the flap. This has been very much supported by Lorenzetti's work for microcirculation and autoregulation of the flap, which suggests that a denervated flap will have autoregulation in case there is an ischemia because of kinking of the pedicle or by any other pressure means. So much so that it adjusts to 70 to 80% of reduction in its blood flow. Hence, it's better to denervate the flap. At the same time, it will also cause the atrophy of the muscle and reduce the bulk, which is not very good cosmetically. There are certain vascular branches which are near the pedicle, which I mentioned them as the feet of the pedicle. They also should be ligated off, or else they would cause bleeding and pressure on the pedicle. Now, coming on to the lie of the pedicle when we are raising large flaps, the issue is that they should lie over the third and fourth perforator. And when a double pedal flap of a larger size is to be used, it is best to have a transverse orientation of the flap. This not only increases the reach of this flap, but also enhances its blood supply, as we see in the representative case. In females, where we are very much afraid about the vascularity, at the same time also the disfigurement of the breast, this is the strategy one should adopt. The pedal should be parasternal, including the third and fourth intercostal. It may even lie over the breastbone a little bit. At the same time, as the flap here that is planned is CDE, there is another flap which is now being lifted from the lateral aspect of the breast, which is based on the second intercostal perforator, the flap ABC. This is the flap which will be turned into the defect so as to minimize the deformity of the breast. This is the flap which has been elevated and tunneled to the neck. The lateral flap from the lateral aspect of the breast has been lifted and it is turned on that side. And this covers the donor defect. The defect covered inside the oral cavity, and that's the final result. Now, when we look at the issue of flap survival, we also need to look at there are other reasons which may also cause complications which are not actually to the vascularity of the flap. And these can very well be circumvented by giving some proper directions to the way we do the flap inset and take control of what functional unit we are reconstructing, whether we are making a microstoma or a macrostoma, or we should restrict ourselves to a normal stoma. The oral competence, and even there is a guide to do a primary animation in these cases. And last but not the least, to get the right contours at the right places. We find that this flap is always been earmarked for being very bulky, but it loses certain areas where it should give its bulk. That is especially in the infratemporal fossa and and the parotidomesenteric areas. We keep talking a lot about the bony reconstructions. When we look at the mandibular reconstruction, we forget that it is actually the soft tissues which are more important for the survival of these uh, bony and the skeleton reconstructions. And the technique of the flap insetting, its contouring and suturing has also need to be looked into. And the proper allowance should be given for atrophy and the post-adhesion changes that these flaps undergo. Complications of reconstructions are more often due to soft tissue issues than others. And that is the reason when our implants also fail. And that's how we need to take care of them. So, method of suturing and insetting, it should also be looked into. Wrapping of the hardware, filling the dead spaces, and if possible, one should also start the animation strategies immediately at the first go of reconstruction. This is where one should look into when we are inserting the flap close to the cut edge of the bone, where there is a tooth and a gingiva available. And I would suggest using a half bursting suture which passes through the interdental space and goes subcuticular to the flap, so that there is a watertight closure there. And this suture can be either of proline, or it can be PDS, or simply Vicryl, but something which has to stand the test of time for at least 3 weeks. Another aspect that I would like to add is that whenever possible, try to preserve the parotid duct, do a cannulation, and relocate it rather than just ligating it off when it is cut. This prevents the postoperative seroma and parotitis to a large degree. When we say the insetting of the flap, it is not just the skin alone, but a lot of things have to be managed for the pec major muscle part, which has to be hitched to the zygomatic periosteum, to the digastric tendon from the inside, the masseteric muscle laterally, the mandible periosteum, or even with the drills through the bone at the cut edge of the mandible. And lower in the neck, it should be spread flat so as to cover the whole of the neck, so that no band formation takes place in the later course of events. Whenever there is a palatal inset of the flap, one should try to pass certain bony sutures through the drilled holes and do a subcuticular suturing of these flaps, or else we'll end up with a fistula. In some cases where we are using large flaps and the double paddle is to be used for the extraoral defect, there is no harm in leaving the outer inset for a later date, because immediately turning the flap to such contours would ultimately jeopardize its vascularity. So many a times I have the sense of advising to leave behind the outer pedal half inset, so that there is no complete congestion to the outer pedal. Now, coming on to the aspect of plates and the soft tissues, as we use the combination, the exposure rate of these implants is around 22% when it is taken into consideration with the soft tissue flap segments. This is not only with the pec major, it is all soft tissue flaps combined with any kind of plate bridging system. Very rarely it fails at the lateral aspect. More commonly, it fails in the central aspect because of the soft tissue cutting through and the overlying skin getting cicatrized and passing through the implants. At the same time, we should also deal with the oral competence and aesthetics of the contour field, which will enhance the outcome of these flaps. It has been very well documented now that obliteration of the dead space medial to the plate decreases the overall plate extrusion by around 20%. It comes down to almost 8% from 32%. In the same way, because we find that the osteocutaneous flaps, when they are used, they have only 10% extrusion rate, because there is a good vascular tissue behind the plate, which is now not letting any dead spaces to occur. So what we need to do is, whenever we have a plate and flap combination, always try to suture the defect above the plate by approximating the muscle to the floor of the mouth muscle groups, so that there is no space left above the implants, and at the same time get every bit of the implant covered by the muscle hitched onto with non-absorbable sutures. Similarly, this is the area where most of the defect is left unattended to. We still have a lot of muscle, but we don't put it in the right place. And that is where seroma takes place or hematoma occurs. And finally, this is where there will be contour deformity and lead to much cicatrization of the flap, which will cause exposure of the plate. The other method is that we can use the tissues of the flap itself, the dermal component of the flap itself, to fill these defects. This is a deep slice segment of the proximal segment of the pec major, which is being used to fill the ITF defect. Once that is done, the another part of this flap, which is now being rolled over the implant, is deep sliced and used to cover the plate completely, so that we have a second layer of cover over the implant. This is much so required because most of the time we find that because of some exigencies of excision, the overlying cheek skin has got a very precarious blood supply, more so because of ligation of the facial artery or the other blood vessel because of the tumor presence. And so this may be at jeopardy. This ensures that we have an intact second layer of skin inside, and it gives a good contour and would also withstand any radiotherapy. Coming to the commissured challenge, should we end up with a microstomia when we have a lip loss and do a secondary correction, or we should do a macrostomia and still do a secondary reconstruction? I would suggest, why don't we do a primary reconstruction straight away? We can use a facial atlas sling, use it to put it across the commissure and do a primary animation here. Similarly, we can also do these things on table with finer aspects as we would do it for a free flap. And these are the post-operative and post-radiation results, which is quite encouraging. Now, when we put our case with PMC versus cutaneous free flaps for the hypopharyngeal defects, that is where most of these flaps have increased morbidity. We find that pec major has a complication rate of around 57% versus 22% with when it is compared to ALT and the radial artery forearm flaps. But the morbidity to the patient is almost half as compared to what it is with the free flaps. So should we not have this case when we say that there is enhanced morbidity of pectoralis major microcutaneous flap, which has been used for salvage in failed oncological treatment, is that because it has already been used in very trying circumstances. Also, with much advancement and the technical skill that is now being put for use in the pec major reconstructions, the flap related complication has come down to almost 22%, and total necrosis is less than 1%. Most of the series these days, they say there has been never a total necrosis of the flap. So it should be taken into consideration that PMC flaps were usually selected to shorten the operative duration due to a poor general condition caused by severe comorbidities. And these comorbidities may exist even with free flap surgery, but the severity being more, they actually are the choice of flap at that point of time. And so the advantage of the PMC with regards to lower medical morbidity should not be undervalued. Now we come to the other aspects of the local flaps, the other flaps, the nasolabial flap being the most common one which is used. It's a simple flap, less time consuming, reliable, and the donor site is very well within the field of the surgery and gives a very good skin match to the surface lesions. But things against it is that it has a facial scar, it has a very limited width, not more than 4 centimeter, and it grows hair when it is taken inside the mouth. The results may not be that happy all the time. We may have sinuses, we may have bad scars, trapdoor deformities, partial necrosis, or hair inside the mouth. See, overall incidence of necrosis is not more than 5 to 6%, whether it's partial or total. Sinus formation is much commoner, up to 12%. And orocutaneous fistula per se is not very common. It's just a 1.2%. And the donor site scar, which may be unacceptable to people, is less than 13% or so. But yes, the incidence of any complication that arises from a nasolabial flap, because it has been used only for small defects, could be left to heal by secondary intentions. So very rarely a second flap or a second sort of a redo surgery is required in such cases. Now, when we have to do some specific understanding of this flap, we look at its use when a facial artery is ligated in the neck. Can we still use the nasolabial flap? Or it would cause necrosis of this flap when there has been facial artery sacrifice. Well, even when the facial artery has been ligated, we still have another other three arteries which supply the flap, which is the transverse facial, there is the infraorbital, and also there will be the contralateral facial supplying it. So if we restrict ourselves to certain guiding principles of the anatomy, we, we see that the flap, the inferiorly based flap, is not taken below the line from the modulus to the lobular attachment to the cheek. The flap will always have a good supply. Flap should always be elevated in a supramuscular plane so as to preserve all the facial nerves, and it should be depthalized up to the follicle depth to prevent any growth of hair tuft or sinus formation, and the outline of the islanded flap should be rhomboid so that the closure is elliptical. And when closing the donor site, one should always restrict to mobilizing the lateral cheek only, and always put a drain so that there is no black eye formation. When my inset is being planned for nasolabial, because it has a very high tendency of trapdoor formation, see that both the inset and the flap are stretched almost to the same tension and stitched accordingly. Coming on to the forehead flap, the forehead and a combination of the glabellar flap, the supply is mainly by the supratrochlear vessel. The dimensions are restricted by how much we can close primarily. Older the patient, we can take a larger flap. Almost the whole nose can be reconstructed with one go. It is usually a two-stage procedure where the pedicle needs to be divided, but has a very reliable vascularity which can be on either side, and has a good color match for the surface lesions of the face. The scar becomes conspicuously obscure because of the forehead furrows. Now, coming to certain examples, this is the defect of a lacrimal gland tumor with a loss of the medial canthus, the upper eyelid and lower eyelid, which has been covered using a forked forehead flap, which gives a very acceptable result. But there can be certain occasions when we have a nasoethmoidal tumor, which has been excised and then subjected to radiotherapy and that ends up with a nasocutaneous fistula. In such cases, a modification of a glabellar flap is very much to be used, where we can take an extension of the galea along with the glabellar flap and use it to fill the defect inside. And so this should be our plan initially whenever we are planning defects which have got a cavitation defect, and a simple cover on the surface would not suffice. These flaps are very hardy and they sustain the radiotherapy quite well. Coming on to the supraclavicular artery island flap, the supply is from the transverse cervical. It's a reliable vascularity. The anatomical landmarks are very critical, and one should stay within it so as to raise a flap which is quite thin, pliable, but the most of the pedicle is formed by a deepthalized segment. The reach of this flap has to be very well planned in reverse, and so one should be very sure about the fulcrum. That's the point where the vessel is actually entering the flap. This disadvantage associated with it is that the donor site leaves behind a scar which is likely to hypertrophy, and sometimes it may need a skin graft. Just an example to show that how much of this flap needs to be deepthalized, the long segment of the pedicle to just supply around 5 by 5 centimeter of defect in the oral cavity. Sorry. The flap necrosis associated with supraglottal flap is around 4 to 15% limited to its tip, and that also happens if the flap has been more than 22 centimeter long. So that is one catch in its length. One has to be very sure about the measurement and the fulcrum of its reach. The dehiscence, which is most common and most troublesome when it is used for a hypopharyngeal reconstruction, happens with salivary fistula in 6 to 17% of cases. And in that, one has to be very sure as to how much of the edge is deepthalized when suturing for the hypopharyngeal defect. The donor side hypertrophy and widening, one has to limit itself to not more than 5 to 6 centimeter in its width. Any complex or maybe the more than one subsite is being involved and which involves the flap to be contoured along that would have adverse effect on its outcome. Smoking also is much associated with much higher rates of necrosis, and nodes at the level 4 and lower 5 would always leave some, I would say, skepticism as to whether this flap was really to be indicated. But the idea where we have to look into is whether we can take this flap even in such cases where these nodes have to be dissected if we restrict ourselves by not dissecting the fibrofatty tissue, which is just medial to the anterior border of the trapezius. We can use a Doppler or even CT angio has been used by people to know as to exact site of the vessel and then go ahead with such kind of dissections. So how do we avoid these complications? We can identify the supraclavicular artery by Doppler or by CT angio when the neck has been previously dissected. Avoid the dissection medial to trapezius. The passage under any skin tunnel should be as lax as possible, and definitely reverse planning that the defect should not be more than 22 centimeter away from its fulcrum should be adhered to with a maximum width of around 5 centimeters. Coming on to the submental flap, it is based on the submental branch of the facial artery. The most important aspect is that the venous drainage should be preserved very well, and this is the flap which would fail only because of its venous congestion. The anterior belly of digastric should always be included because the perforators come through it, and this flap needs to be harvested before the neck dissection is done. Then there is always a question mark with level 1 and B dissections with its oncological safety and the flap. So that flap may not be of use when these nodes are positive. It's a very hairy flap, and so in males, it's a big no-no. This is just an example to show a defect at the angle of the mouth with the buccal mucosa and the outer skin. A flap has been elevated, and both intraoral and extraoral defect has been covered. Very healthy looking donor side defect, which is very inconspicuous. That's the positive aspect of this flap. But yes, it has complications related to marginal mandibular nerve, which runs around 0 to 17%. So some people have even advocated doing a supraplatysmal submental artery perforator flap, which would minimize the risk to the marginal mandibular nerve, but that becomes very technically demanding. Venous congestion is around 5% in these flaps. So one should always preserve the anterior jugular vein when it is being divided at the anterior edge of the anterior belly of digastric, which may be of use to be anastomosed if we find this flap has congestion when it is transferred inside the oral cavity. And this vein can be used as the donor vein. The necrosis, which is mostly partial, is limited to 0 to 5%. And intraoral hair growth definitely is one of the complications which we cannot avoid. It can always be treated by some lasers or by epilation, but it is too big a issue for such dense hair growth. The risk factors associated are any node positive neck. We will not be doing the submental flap. Any previous neck dissection or radiation to the neck, these flaps would ultimately end up with venous congestion. And there may be a ground for doing a Doppler assessment of the venous circulation in these cases, but still that would be a high risk. Incorporation of anterior belly of digastric should always be encouraged, and anterior jugular vein should always be preserved when the flap is being elevated. A word about the temporalis muscle flap. It's a robust flap with good blood supply, which is ensconced in the muscle and the bone. It is mostly used as a filler flap, but definitely has a donor side contour defect. Necrosis is very rare. Total necrosis is very rare. If the dehiscence is more common, up to 7%. And many a times it is left to epithelize as a secondary thing, and that becomes delayed because of either dehiscence. So I would suggest that one should always make a case of putting a skin graft on the surface of the muscle, which is being used for intraoral defects. It has a poor reach to the opposite palate, which can be enhanced by a technique of including the pericardium and the galeal fringe. The injury to the temporal branch of the facial nerve has always to be avoided by not venturing into the fat pad above the zygomatic arch. And there is a great amount of difficulty encountered when passing this flap under an intact zygoma. I don't advocate cutting the zygoma just for the purpose of passing this flap. One has to be a little diligent and one can always do that. So these are certain points. Always take a fringe of pericranium attached at its outermost limit. Also a border of the galea, which is the temporoparietal fascia. Both of these maintain the attachment of the muscle in the original form, and so this attachment to any part of the defect would be very stable. The temporoparietal fascia, which has been dissected off, should be preserved to its full entirety, because that would be then put back to decrease the contour defect. And a word about this pad of fat, which is always seen at the upper border of the zygomatic arch. If we don't go into this pad of fat below the zygoma, the temporal branch of facial will never be injured. I'll just skip this anesthesia consideration because this would not concern us much, and come to the conclusion that when we reach the end of what we should know, it will be the beginning of what we start sensing. And that is what is the sixth sense when we say about anything that, oh, this will do well. So if a person wins without any trouble, that is victory. But if one wins with a lot of trouble, that is history. I hope I was informative enough, and I will hand over the charge to the organizers, and thanks a lot.
Thank you very much, Sandeep sir, for this practical and in-depth excellent talk. I think we will take up the questions after our second talk. So let's quickly move on to our second talk, and the second speaker I would like to introduce is very dynamic Dr. Deepak Balasubramaniam. He is associate professor at Amrita Institute of Medical Science, Kochi, in the Department of Head and Neck Surgery and Oncology. He participates in the entire length and breadth of head and neck cancer surgery as well as reconstructive surgery, and he is very active in academics also, with numerous papers, chapters, and reviews to his name. So, may I please invite Dr. Deepak? Over to you, Deepak, sir.
Yeah, I'm just going to share the PPT. Is the PPT
Yes, it's visible, sir. Go ahead, sir.
in everyone's screen? So at the outset, I'd like to thank the organizers for giving me the opportunity to make this presentation. And it's always humbling to do a presentation after Sandeep sir, because his presentations are full of pictures and practical tips on how to get by doing flaps and the complications of flaps. The topic that was given to me was complications in free flap surgery, and a lot of the practical complications that you would encounter in terms of dehiscence and hardware exposure or contour deformities, Sandeep has already spoken to, and the principles are more or less the same. I'm going to be speaking specifically on what happens during free flap surgery, how to anticipate problems in microvascular anastomosis, how to get by or solve those problems during microvascular anastomosis, and briefly look at donor site morbidity and how you execute flaps when you're planning to reconstruct head and neck defects. So it is very clear that free flap microsurgery has revolutionized head and neck reconstruction over the last 3 decades, and it's very safe and effective. The high volume centers have a flap success rate of more than 95%, and we are not limited by the defect anymore. Even complex three-dimensional defects, large defects, can be safely reconstructed, provided we understand the limits of the flaps that we harvest. The surgical principles have remained the same. New flaps have been described, but the surgical principles for the three workhorse flaps, that is the radial forearm, the ALT, and the fibular flap, has always remained the same. One should remember that this is an all or none phenomenon. Either the free flap works in its entirety or the free flap doesn't work. So that point specifically is for the microvascular anastomosis. So either the anastomosis works or the anastomosis does not work, and we need to pay critical attention to that. Management of complications is essential learning, because if you have a failed flap, you should always be in a position to redo the flap. If you run into a complication with the anastomosis, you should be able to correct the complication. So learning how to manage these complications is very essential. And when you do free flap surgery, always have a plan B in mind, because in spite of your best efforts and astute operating and meticulous surgery, we might still end up losing the flap. So always have a plan B in mind and don't burn all your bridges. So for successful free flap surgery, we have like the common goal would be to have an anatomical and functional restoration. That would be the aim of any free flap surgery. But what is under the what is important to get the anatomical and functional restoration is to have proper anastomotic technique. If you know how to do the anastomosis correctly, your flap will survive. And also understanding flap physiology and ischemia time. I'm not going to go into the depths of how you harvest an ALT or a fibula or a radial forearm, but we all should understand that there are physical constraints in how much of muscle or tissue that we can harvest along with a free flap. And more importantly is to understand this concept of ischemia time. So all of the tissues, once we ligate it from the donor area, all of them can withstand ischemia for varying durations of time. And the ischemia tolerance depends upon the energy requirement of the tissue and the duration of the ischemia. So some tissues, for example, muscle, viscera, have very low ischemia times. Whereas if you look at bone and skin, they probably have higher ischemia times. But it doesn't mean that if you have a tissue which can tolerate ischemia better, you can do the procedure slower or you can take your time doing the anastomosis. If you limit the ischemia time sufficiently, you're going to end up having fewer complications than ending up with major complications. And what happens is when you have short duration ischemia, there's a lot of adaptive responses which happen within the tissue. There's a lot of activation of cell survival programs, and basically the tissue can revert to its functional state or to its anatomical state once the ischemia is removed. But the longer you prolong the ischemia, the cellular dysfunction becomes permanent. There is tissue death, and this makes the flap non-viable. So always remember, different tissues have different ischemia times, and you try to do the anastomosis and get the flap perfused as soon as possible. So what are the complications that we can have during free flap microsurgery? So you can have intra-op complications, you can have immediate post-op complications, and you can have delayed complications. The intra-op complication is always due to either the anastomotic technique or the problems within the vessel itself. Patients can have different types of vessel pathology. And there are a wide variety of reasons for that. You can have arterial problems, you can have venous problems, you can have vessel orientation problems, you can have external compression of the pedicle, or you might have inadequate length of the pedicle, thereby causing you to do anastomosis under tension, which is not a good thing to do. So the most of the problems are because of the anastomosis and the technique of anastomosis. And in certain patients, we always have other problems that you have to think of. For example, intravascular pathology. So anticipation is the key here. What we commonly see as problems within the vessels are atherosclerosis. You might see intimal dissections, and you might see thickened or calcified walls. Now, there are some warning signs. For example, patients with hypertension, diabetes, peripheral vascular disease, and smoking. These patients have a higher incidence of having these intravascular problems. So, to a certain extent, you will be able to predict it by doing preoperative studies. For example, in the fibular flap, either doing a Doppler study or a CT angio will give you an idea of the course of the vessel and the luminal diameter, and or if there's any other narrowing within the vessel. But most of the time, it's usually overt only when we are operating. It becomes obvious only when we are operating. So the problem with atherosclerosis is that the vessel lumen is narrowed because of the plaque. The problem with an intimal dissection is that there is a false lumen created within the vessel, and the blood tends to flow there and then eventually cause thrombosis of the vessel. And in cases where the walls are very calcified, it is difficult to drive the microvascular suture through. So the solution for the atherosclerosis as well as the intimal dissection is that do not handle the vessel unless absolutely necessary. And at no point should you do any maneuver that dislodges the plaque within the vessel lumen. Always use sharp scissors to make the cuts at the end of the artery, because any serrated cut or any grinding cuts will cause the plaque to separate or will cause the intimal dissection to become worse. And you should remember that the atherosclerosis or the plaques need not be a continuous phenomenon. The vessel will be beady and thick at different points along its course. So all you need to do is to cut back till you get a healthy lumen to pass the suture. You do minimal adventitial preparation, again not to manipulate the vessel too much. You have to place the clamp gently on the vessel, because any rough placement of the clamps can dislodge the plaques. And use or try doing clampless anastomosis, for example doing the back wall in from outside to in to inside to out. If you're looking at a vessel which has got a plaque inside it, you always have to follow the inside out technique, so that when you take the needle and drive it from the lumen through the vessel wall, the plaque is plastered to the vessel wall and does not dislodge. So you have to be adept at passing the suture in the reverse direction, or you have to be adept in doing a back wall front wall sort of anastomosis. And if the vessel wall is heavily calcified and thick, you can use a 70 Surgi-Pro microsuture, because the needle is very strong and it tends to pass through a calcific vessel much easily. So veins generally do not suffer from vascular pathology. The most commonly encountered anatomical problem is that there are valves. And these valves are usually seen in the bullous parts of the veins, where the vein has a slight bulge, a bluish bulge. You know that the valves are there. The valves are there for a reason, to prevent reverse flow of blood. But we have to be careful when we're suturing an area that there is a valve. You can always cut back to an area where the vein lumen is clear. You should avoid picking up the valve during your suture if that is possible. Otherwise, take full thickness bites, including the valve, and plaster to the vessel lumen, to the vessel wall, so that it doesn't cause any floating fragments within the vein lumen. Now, vessel orientation and external compression is a very important point that you have to remember. So, because in most of the head and neck defects, the pedicle is tunneled through other soft tissue, or in the cases of a fibula flap or any other bone flap, it is tunneled under the newly placed bone and hardware. So, our principle is always flush the artery with heparinized saline prior to the anastomosis, and watch for unobstructed venous return. If there is any resistance in the arterial flush, then there is a torsion of the pedicle or external compression, or there's an accidental lega clip distally. You have to watch out for all of these. And the above steps are crucial before you start doing the micro, because once you've done the micro and you find that the flap is not perfusing because of torsion, you cannot correct the torsion unless you take down the anastomosis. So it only adds to the stress and increasing the ischemia time. So the good habit would be to try and flush the artery always with hep saline. Look for the unobstructed vein flow before embarking on doing the microvascular anastomosis. And vessel orientation should be done in such a way that there is no tension to the anastomotic site. A gentle curve of the pedicle is preferred if there is excessive length of the pedicle. And sometimes you may need to suture the pedicle to the soft tissues of the neck to keep it in place. So these are some of the things that you can try and do to avoid kinking or unnecessary, turns of the vascular pedicle. So what happens if you have a non-functional anastomosis? So you've done the milking test, distal to the anastomosis, and you don't find the arterial flow into the flap, or the flap shows no bleeding or is congested. You have to rule out the following problems. Either whether there's a compression or not on the vascular pedicle. You have to make sure that the patient is not in hypotension. Sometimes inotropic supports will cause vasospasm of the perforators and the distal pedicle, and may mimic that the flap is not getting perfused, or the vessel can be in prolonged vessel spasm, which can be corrected by papaverin or topical lidocaine, or keeping warm saline sponges. So you have to rule out all of these things before you take down the vascular anastomosis. And in more often than not, it's usually the hypotension or the compression that is the problem. So you have to pay particular attention to the course of the pedicle and the tunnel, and always keep checking with the anesthetist whether the patient is maintaining normal BP or not. So what are the problems within the arterial anastomosis? So when you look at a non-functional arterial anastomosis, there are three problems that you will encounter. One is that the anastomosis doesn't work and you have a sticky platelet plug inside, or you can have partially organized thrombus, or you can have a fully organized thrombus. A sticky platelet plug is, you'll find fine specks of reddish colored platelet plugs in and around the vessel lumen. They are quite easy to dislodge by a rapid saline flush, or you can remove them with your jeweler's forceps. A partially organized thrombus also can be removed with the jeweler's forceps by forceful saline irrigation. But the fully organized thrombus is quite tricky, because if we try to do an aggressive thrombectomy, we might damage the intimal layer of the vessel. So what you do in such a situation is that you cut back either on the neck vessel or on the pedicle artery, and then you find a suitable lumen where there is not, where the thrombus hasn't extended to, and then use that part of the flap artery. And in the neck, you can always look for a second vessel. I always, when I plan to do an arterial anastomosis, I always expose the superior thyroid as well, so that if there is a problem with the facial, I always have a second vessel that I can do the anastomosis to. So you have to be very careful in doing an aggressive thrombectomy, because that will can damage the intimal layer of the vessel. And then try and redo the anastomosis with a finer microsuture. And you can always consider heparin infusion in these patients. You can give 5,000 units of heparin IV, or you can give an heparin infusion in 500 ml of saline over 8 hours. And this will keep the microthrombi from forming once you've redone the anastomosis. So the vein thrombosis is usually due to a kink in the vein position, or it can be due to a distally ligated vein in the neck side. And this is common when you use the EJV, especially, and the level 5 neck dissection has been done. The EJV may be damaged as it courses behind the sternocleidomastoid muscle, and there might be a clip or it might be tied. So what I do is, for all veins that I do, I flush the vein in the neck aspect to see whether the saline is leaking from any wound in the neck or any corner in the neck, or if the saline is flowing without any impediment. So always try to flush the vein before you're doing the vein anastomosis. The same principles as in arterial thrombosis, but before you take down the vein, make sure that there is blood flowing into the flap as well. So always check the artery before checking the vein. What are the immediate post-op problems? The commonest problems are anastomotic failures and hematoma. Hematomas can be diagnosed by the skin being, the neck being enlarged, or a collection under the neck, a fluctuant collection under the neck. If it's an organized thrombus, there is erythema of the skin around the suture site. And basically, any change in the contour of the neck in the immediate post-op, you should suspect that there is a hematoma, and you should proceed to evacuate it, even if it means it's being done in the bedside. So the other common problem is the problems with the anastomosis. Now we have to break the anastomotic problems into two time frames. One is problems which are there from the first to the third day, and the second anastomosis failures are the ones which are beyond the third or fourth day after the surgery has been done. Usually the first to 3 day problems are not infective, and they can generally be redone because the tissue planes are not contaminated by saliva or muck. Whereas usually if it's beyond 3 or 4 days, you always suspect infection or a salivary leak, and this is harder to correct compared to a 1 to 3 day anastomosis failure. So you do a surgical re-exploration, obviously, the same principles as that of the intraop failures of microanastomosis. So you do the same thrombectomy, you do the cutbacks, you redo the anastomosis to alternate vessels, or you try to find a vein graft for a distally placed neck vessel. You always check the artery and vein both. Don't ever check only one vessel, because the flap was either delayed or the flap was congested. You have to, once you're in the neck for a re-exploration, you always check both the artery and vein. And the critical time for re-exploration is less than 2 hours, because the longer you wait, the chances are that the thrombus is going to organize and you're going to have difficulty in doing a thrombectomy. And always try to find the cause of the thrombus, because usually if it's an anastomotic technique, for example, if you've picked up the back wall, or you've included the intima of the back wall in your stitch, or if there is some free floating debris in the vessel, it usually manifests very easily on table itself. By the time you close the flap, you'll see that there is a problem. But if you have a problem that has taken 2 or 3 days to occur, look for places for hematoma, look at the vessel pedicle orientation, see if the skin is too tight or the tunnel is not wide enough. So you have to look at, if possible, try to find out the cause for the thrombus. So anastomosis failure, you correct the systemic, identify the anastomosis. Sometimes it's quite difficult because of all the fibrin plaques that usually form over the neck soft tissue. So you have to identify the anastomosis first under the microscope and avoid manipulating the anastomosis too much because the tissue can be friable. You examine the artery first. If the artery shows a thrombus, you evacuate the thrombus from the pedicle, or if there's a thrombus in the neck source vein, you evacuate the thrombus from there, or you find another source artery, or use a vein graft to reach a distal artery. Usually it's not the case because we have the external carotid in the neck. We have numerous branches that can be sacrificed. So usually we don't have to take a vein graft to go to the transverse cervical or any of the arteries in the chest, but it's possible if you can expose the external carotid, that would be the best way to go. And then you redo the anastomosis. If there's a vein thrombosis, you evacuate the thrombus and you can try and remove the clip from the second venae comitans of the flap. All of the flaps have one artery and two veins, or most of the flaps have one artery and two veins. So you can always try and open the other vein to see if there is flow. But in most instances, the other vein would have already thrombosed since the time of surgery. So it is quite difficult to use a second VC, especially if it's a second or third day re-exploration. You find another source vein. The commonest vein that you can use again is to do a end to side internal jugular anastomosis, or you might have to use a vein graft to come to the IJV, and then you redo the anastomosis. But in spite of a successful anastomosis, meaning the anastomosis technique was good and you're able to see blood flowing into the flap, but the flap doesn't push out any blood into the vein. Now you're in a phenomenon called the no flow phenomenon. And this low flow phenomenon is actually a very difficult problem because this usually happens if there is prolonged ischemia and a delay in us taking up the case for the surgical re-exploration. The changes are not in the macro circulation, but in the micro circulation. And because there is damage to the vascular endothelium in the zone 2, zone 3 levels of the microcirculation, in spite of the artery pumping blood into the flap, we don't have a venous return. So this is a problem, which means that the flap is not viable. People have tried to use intraarterial streptokinase to try and break the microthrombi within the microcirculation, but it seldom works. So if you've come to a point where the artery is pumping blood in, but you're not seeing any venous return, it's probably because the the exploration took time, or it was a missed failure, and these flaps are generally not viable, and you have to consider an alternate flap. Now, the delayed thrombosis, that is what happens after the third or fourth day of the surgery, is secondary to an infection or fistula. And they're very difficult to correct because the vessels are very friable, the vessels are infective. Even if you redo an anastomosis or do the second vessel or do a vein graft, because the bed is infective, there's always a chance of anastomosis blowout. They are prone for rethrombosis even if you successfully do it, and it's a progressive problem. You wait till the infection clears and then you plan an alternative flap, and you debride all non-viable tissue to prevent superadded infection because of the dead tissue in the neck or in the oral cavity. So these are some of the delayed problems. Here you can see a patient who has a complete loss of the skin paddle of a fibular flap. This is another fibular flap where the patient had partial necrosis of the fibular skin. And this is another patient where the complete flap was lost. This was a Tdap that I had raised for a buccal mucosa and palate. And he had very tight skin because he had multiple flaps and multiple surgeries. We had done the anastomosis to the superficial temporal artery, and the flap failed because of external compression on the fourth and fifth day. So you can have delayed problems in flap losses. And the problem is it's an all or none phenomenon. If the skin goes, you always have to think about putting another flap inside. It can be a secondary free flap or it can be a pedicle flap after that. But unless you correct the underlying problem and why this flap failed, could be an infection, could be a bad inset, could be hardware that was pressing against the vascular pedicle. Unless you correct the underlying problems, your second free flap also is likely to have the same complications. The one major issue in putting in hardware and putting in a bone flap is that you have to have adequate viable soft tissue cover for these flaps and for these implants. So the problem is, if the flap breaks down and you have an exposed bone, it usually means that the bone will get devitalized at some point of time. And exposed bone and hardware needs to be closed immediately with a local flap or another free flap. Otherwise, we're going to lose the bone, the hardware, and the entire purpose of the first surgery. So exposed bone and plate needs to be closed as soon as possible. So how do you avoid distal skin paddle loss? This is the commonest problem that we see when we take ALT flap, or we take a large skin paddle based on the for the fibular flap. You have to respect the angiosome concept of Taylor, because all of the vascular territories of the skin are perfused by selected perforators along, through the entire human body. So Taylor in his angiosome concept said that you can take the perforated territory, one perforated territory, and you can take the adjacent perforated territory, but not the perforated territory once removed. That is, you cannot take the skin from the third perforated territory, because the choke vessels do not have enough pressure to push the blood to the third territory. So I suggest all of you read Taylor's work. There's a Clinics in Plastic Surgery which describes the angiosome concept and its application in reconstruction. So always try to take the tissue from your perforated territory, or at the most you can take the adjacent perforated territory, but not the perforated territory, which is at once removed. And always inspect the edges of the flap for vascularity. So at the end of the harvest, before disconnecting the flap from the donor side, for example, in the ALT, you always cut the skin at the distal skin area and to see if the flap is bleeding there or not. If it's not bleeding there, then you discard that portion of the skin flap. If you're going to take a skin flap which is very large from the ALT territory, it is better you center the perforator on the flap rather than having it at one edge, which increases the chance of distal necrosis. And always avoid thermal trauma to the dermis when raising the flap, because a large part of the blood supply is in the dermal plexus and the subdermal plexuses. So try to avoid thermal trauma to the dermis, especially if you're raising a suprafascial ALT. Avoid the no inset should be under tension, because any inset under tension is going to cause dehiscence, and because of the undue tension at the wound edges, the distal edge may necrose. And don't overdo closures with a single flap. If your defect is so large that a single flap cannot reliably close the defect, always consider using a second pedicle flap to compensate for the primary free flap's insufficiency. So don't overdo the size of the flap, nor do you overdo the defect that you're trying to close. So this is Taylor's angiosome concept. So if you take, for example, the ALT flap, so this is the perforator for the ALT flap. So from this, you can take the skin from this vascular territory, and then the geniculate artery supply near the branch of geniculate artery supply near the knee. So you can include both of these vascular territories in your ALT flap, but you cannot take skin from the shin or from below the knee joint. So you have to respect the angiosome territory concept, because that will help you decide what is the maximum limit of flap that you can harvest. So flap dehiscence is a difficult problem to correct. The reason why I say it's difficult is that most of the dehiscences are because of a technical problem. Either the flap was too large, was too small, or the flap was sutured under a lot of tension, or the mucosal edges were not vascular or viable enough. Like, for example, patients who've had radiation before, or patients who have scar tissue like submucous fibrosis, or patients have had multiple surgeries in the past. So it is a difficult problem to correct in certain circumstances. Flap dehiscence can lead to fistula formation. In my book, early resuturing after debridement is essential. Just like how Sandeep sir mentioned, that if the edge is approximate and the edges are viable, you debride what the non-viable tissue is, and then you start suturing it. But if you have a dehiscence which hasn't resulted in a fistula, you can always wait and watch. You can't do pressure dressings like how you do for a pedicle flap, because you might compress the vascular pedicle, but you can allow the wound to heal by secondary intention, provided the saliva doesn't start soaking the vascular pedicle or the anastomosis. So always remember that dehiscence puts the anastomosis at risk. If the flap has survived for 7 or 8 or 10 days, and then you notice the dehiscence, you can probably wait for it to heal by secondary intention. But if you see a dehiscence in the first, second, or third day, I would suggest that you go back and resuture the edges. So the principles of redoing a flap or doing a secondary flap is that you always establish the presence of suitable vessels in the neck. So you can do a neck CT angiography to make sure that the vessels are there. All you need is the external carotid and the IJV. If the patient's IJV has been ligated, you can do a cephalic flip where you dissect the cephalic vein starting from the just above the wrist in the forearm, in the arm, up to the deltopectoral groove, and then you flip it subcutaneously into the neck to act as a receiving vein. Or you can do the anastomosis to the opposite side of the neck. Always inspect the vessels for flow before committing on a free flap harvest. Don't harvest the free flap unless you're happy with the arterial flow from the neck side and you're happy with the vein quality. Always inspect the vessels before you commit to raising the free flap. Make sure that the mucosal edges and skin edges are debrided. Very important, because if you suture non-viable tissue together, they're not going to heal. And free flap, the harvest technique of the free flap is the same principles as you do for a primary free flap reconstruction. Another overlooked problem is the donor site morbidity. So if you look at the three flaps that we use, the ALT, the fibula, and the radial forearm, skin graft loss is a common problem. The second problem is dehiscence, especially if the wound has been sutured very tightly. Compartment syndrome is rare because we usually cut all the, it's a basically raising a radial forearm and a fibula is like doing a fasciotomy. So most of the vascular compartments are exposed and without pressure inside. And there can be loss of sensation, stiffness of the extremities. So the loss of sensation comes with part of the morbidity of the flap because the skin territory will be numb. But in the cases of the radial forearm flap, always try to preserve the cutaneous nerves, and I'll talk to you about that. So these are some of the problems with skin graft take and loss of the skin graft. So the reasons why skin graft take is not good or is not complete is that the bed wasn't prepared well enough. So you should always avoid hematomas. Make sure that the bed does not have any bleeding. Any devitalized tissue in the bed has to be removed, and the skin graft has to be tacked to the floor of the defect and should be securely sutured by quilting stitches and using an overdressing. The systemic causes are patients who have diabetes, patients who have hypertension. These patients also have poor wound healing of the graft site. So you debride the wound and the devitalized tendon and muscle. Usually it's the brachioradialis in the radial forearm or it's the peroneus in the fibula. Use vacuum assisted closures like VAC devices to reduce the wound size, and then redo the skin graft and make sure this time you avoid all the problems or all the pitfalls that is associated with the skin graft placement and fix it firmly to the bed of the wound. Sensory loss is common if you damage the superficial radial nerve during radial forearm flap. They have an anesthesia over the anatomical snuff box. You have to try and preserve all the branches of the superficial radial nerve. During a fibula flap harvest, the sural nerve and the superficial peroneal nerves are at risk. They must be preserved at all costs, especially if the patient is diabetic or they might have problems with foot and heel sensations later on. The lateral cutaneous nerve of thigh is not very easy to preserve because sometimes the skin paddle may belong to the territory supplied by the lateral cutaneous nerve, but in a small ALT, this has to be preserved as well. Compartment syndrome, as I mentioned, is rare. You avoid tight closures and you always watch out for cold extremities, no SpO2 on the pulse ox, pain, pins and needle sensation, or skin blistering, because all of these are signs that the patient is having an impending compartment syndrome. So to conclude, the proper flap choice and anastomosis technique is key for the success of any free flap surgery. You have to design the free flap to capture the best vascularity and don't overdo the length and breadth of the flap that you're raising. Anticipation of anastomotic complications is essential, especially if you have bad vessels in the flap or in the neck. Redo the anastomosis as soon as possible, as soon as the problem is detected, because if you wait too long, either the thrombus becomes completely organized or the patient will have no flow, no reflow phenomenon. You protect the anastomosis from leaks by suturing any dehiscences early and preserve your pedicle flaps as a lifeboat in case your free flap failure occurs. So thank you for your time, and any questions, I'll be happy to take them.
Thank you very much, Deepak sir, for your truly crisp and practical session. Now we'll take up some questions. So there is a question from the audience. The first question is low molecular weight heparin helpful? And also, sir, if you can discuss the protocol, anticoagulation protocol at your center.
So in most centers and in most studies, they have found that you really don't have to heparinize the patient after routine microvascular anastomosis. In fact, the heparin that we give, Clexane and Amrita, is only for the DVT prophylaxis. We only give 0.2 cc subcut once a day. So we never give heparin, we never give a higher dose of Clexane. So basically, you just give enough to prevent deep vein thrombosis, and that's it. It is nothing to do with the anastomosis. And I would start systemic heparin if there was a problem on table with thrombosis, and you don't want microthrombi to form. And that's also, it's not based on very solid evidence or anything. It's just a routine practice that we have here. So I wouldn't do that routinely for patients, except that they receive low Clexane 0.2 cc for DVT prophylaxis. And I think there's a question on low molecular weight dextran.
Yes.
So we stopped using dextran a long time ago because dextran has been associated with having increased lung complications. Patients who received dextran, they found in many studies, including the Amrita study, that their chances of lung complications were higher, and it did not add to any improved survival of free flaps. So I think in most centers around the world, they stopped using low molecular weight dextran for their routine flaps. I don't think they use it at all in any of the centers.
Yes. Right. So I think we will take up rest of the questions after the panel because many of the questions would be probably answered during the panel.
Yeah, that is great.
So yes, thank you. So now we can move on to the panel. So for all of us, there are certain real life situations that cause a great deal of distress and frankly leave us short of answers as to the management. Uh, for this, we welcome Dr. Dushyant Mandlik, the moderator of the panel. Dr. Dushyant Mandlik is consultant head and neck reconstructive and robotic surgeon at HCG Cancer Center, Ahmedabad. He has keen interest and insight in ablative as well as reconstructive surgeries, with notable original contribution in the field. He was awarded the UICC fellowship under one of the pioneers of reconstruction, Dr. Mark Arkin. He is fellowship director at the HCG Cancer Center, secretary of FHNO Institutional Fellowship Program, and member of Education Committee of Golf Program of IFNOS MSKCC, and EC Committee member of FHNO. May I please request Dushyant sir? And also, I would like to introduce our esteemed panel who are with us today to be part of the discussion. Our first panelist, Dr. Prabha Yadav, madam. She is HOD of Plastic and Reconstructive Department at Sir H.N. Reliance Hospital, Mumbai. Dr. Subramaniam Iyer, sir, HOD, Department of Head and Neck Surgery and Plastic and Reconstructive Surgery, AIMS, Kochi. Dr. Akshay Kutpaje, consultant head and neck surgical oncologist and reconstructive surgeon at HCG Bangalore. Dr. Soumya Matthews, consultant plastic and reconstructive surgery, TMH, Mumbai. Dr. Amit Chirom, consultant department of otolaryngology, AIMS, Delhi. And may I also please request our speakers, Dr. Sandeep sir and Dr. Deepak sir, to be available for the panel discussion. Over to you, Dushyant sir.
Good evening, everybody, and it is so good to see a large crowd to have this niche conversation on reconstruction and complications of reconstruction in head and neck. It is really heartening to see the interest. I think you are able to see my screen.
Yes, sir. Please go ahead.
So this is the 5th session in the series of 6 sessions. Today we are going to talk about reconstructive surgeries, complication and management. We had excellent talks by Dr. Sandeep and Dr. Deepak, who has covered almost all the aspects of complications in free flaps as well as in the local flaps, and had an excellent presentation. We would like to cover certain scenarios during our this reconstructive session surgeries. We all, love Hagar the Horrible. He is such a positive person. He always throws a smile whenever there are certain complications or certain problems. And he is very well known for his appetite also. But even Hagar has sometimes problems. And he asked God, why me? And then God says that, why not you? You are not something. And this happens to all of us. Everything is going fine. All the flaps are turning good. And suddenly you have a series of 1, 2, 3, 4 complications, and you are kind of questioning, why me? When I was actually preparing this presentation, I went through this very well-known book of Way and Mardani, and I was reading this Avoiding Complication chapter by Jeremy, Andrew, and Wynne. And it is actually reflecting what all of us thinks. It says that it is something of a dent to personal pride to be singled out among so many internationally distinguished contributors to write a chapter on complications in microsurgery. How did editors know we were so experienced? Maybe our panelists and our lecturers must be thinking same. We would like to be able to make the same boast as an esteemed surgical mentor who, when asked to speak on complication, warmed to the subject by stating that I am an authority on complications. I saw one once. Sadly, good judgment comes from the experience, and experience comes from the bad judgment. And we at least qualify from the experience side of the equation. So whenever there are complications, and when we deal with the complication, what they leave to us? The complications will leave 2 holes instead of 1. Like we take a flap, we take another flap, and there are 2 rents. Telltale limb scars of vein grafts, salvage trace of desperate surgeons and hematomas, introductory from inquiry of relatives, the shattered confidence and bitter disappointment of the patient. And for us, we always kind of have self-doubt. What more could I have done to make this work? Was it a bad tissue, assistant, the anesthetist, our favorite one, the nurse monitoring, or just a good surgeon out of luck? And why am I doing this microsurgery? Do I need this? How did I get into this mess? Who can I share it with? And last but not the least, where is caustic soda and which way was the river?
Dushyant sir, just before you continue, one more panelist I would like to introduce is our very own Dr. Dhanusha Gohil. He is a consultant and plastic reconstructive surgeon at HCG Ahmedabad. He is also going to be part of our panel.
Dhanusha, welcome. And I would like to add that Dhanusha is a kind of Robert's shoulder. He is doing 350 plus free flaps, and we are happy to have him. So we will like this panel to be very kind of conclusive, to the point, and sharp, with take-home messages. For every case, we will like to have the discussion on what is this complication, how we could have avoided it, and what can be the corrective action, and any other innovative inputs you have. As we all know, we want to identify if there is a failure in planning and execution, or failure in the post-operative care about the patients. So we will start with our bread and butter day-to-day challenge, that is vascular compromises in free flap. Deepak has very elegantly covered everything almost in the free flaps, but I will still like certain cases to be discussed by our esteemed panelist, and I will introduce you with 3 case scenarios which I have with me. In case 1, it is POD4, and I have reconstructed the tongue with a free radial forearm flap. As you can see, that part of the flap is congested, part of the flap is good. In scenario 2, in a hemi tongue, we have reconstructed it with an ALT flap. It is day 5, and flap has started giving congestion at the edges of the flap. In part 3, there is a bilobe ALT for a full thickness defect, and this is day 8 of the flap. Flap is swollen, flap is edematous, but still it is bleeding good. I would like Akshay to comment on these 3 scenarios, and I would like him to tell that how he is going to manage this flap, what he will do with these flaps. Akshay.
Yeah, thanks, Dushyant. In the scenario of the flap 1, I would, since there is just edge, the flap edge is slightly discolored and rest of the flap is bleeding well, I wouldn't be much worried about that flap unless my drains are not working and if I'm suspecting early or the fistula connecting to the neck. The second scenario in which the flap looks dusky and in this situation I would consider exploration, and this is a situation, it's day post-op day 4 or 5. So there is a chance that the patient has developed a fistula to the neck, and we need to go and clean up the neck and check the anastomosis as well. On the third scenario, the flap looks, it's just flap is swollen. If I examine the neck, there is no collection in the neck or any obvious signs of any hematoma, I would still wait and watch in the class 3 and the case 1 and case 3 scenario. I will be happy to wait and watch if there is no hematoma and other signs. But class 2, definitely I'll take it to theater and open up the neck and have a thorough walk and inspect the anastomosis.
Soumya, you will like to have any other things? You will like to differ with Akshay in some way, Soumya?
In the first 2 case scenarios, I think I agree with Dr. Akshay with what he said. Case 3 would depend on what I experience intraoperatively with this flap. If there was any issue with the perforators to begin with, and things as such, because at times waiting on some flap like this would mean that it's wishful thinking and it would just mean that it would result in an orocutaneous fistula and make that side of the neck contaminated, which may preclude my further reconstruction that it would require.
So what you will do? You are muted, Soumya.
In case the skin flap, hello?
Yeah.
Yeah. Okay. In case there is like skin peeling from that flap in case scenario 3, I would possibly take down that flap without waiting any further, only so because if there is an orocutaneous fistula that may develop in this scenario, it may preclude my further reconstruction. But scenarios 1 and 2, I agree with Dr. Akshay what he said.
Dr. Dhanusha, you will like to add something or?
Yes, sir. In case scenario 1 and case scenario 2, I totally agree with Dr. Akshay. But in case 3, I would like to do some comments. As Dr. Soumya already told that there is some we could find out some intraoperatively another picture. But one point I agree with Dr. Akshay that the flap is swollen. So I would like to do a removal of suture surrounding areas. So that might be helpful, and then it gives the blood supply to the what actually we seen in this scenario surrounding stitch line. So I think I would go for the first open the stitches and then want to wait.
Okay, so I think for first you will wait, for second you will go in and open, and for third you will release the outer pedal. Amit, you have something else to add to it, or you agree?
No, I would like to know the intraoperative. How was the designing of the flap, and for the case 1, whether the venous is the congestion on the peripheral part is mainly it looks like a venous. So whether you have taken the deeper venous system or the superficial venous system or both anastomosis.
If you have taken both.
Yeah. So it's a single anastomosis or a double anastomosis of the vein.
I've done 2 anastomosis, one with superficial and one with deep system.
So this one I would like to wait, because even if most of the time the flap is either all or none phenomenon, but this seems to be only edges seems to be a bit congested.
Amit, can you tell me that why this happened to a part of the flap and why other part is okay? Can there be anything which is making it discolored only in part and the other part is fine?
The planning of the flap, whether it means where you have taken the congested part, whether it has got the proper venous drainage or not, that is also important.
Okay.
And for the case number 3, the condition of the supply of you must have taken a bipedal one in this, both for the inner and the outer lining. The outer lining and the inner lining, the condition is a bit different. The perforator you have used for the inner, that might have gone some problem with that.
Okay.
Can I add something?
Yes, Deepak, please.
So in case 1, I think it's probably because of the acute turn of the radial forearm, where it's going from the tongue to the floor of mouth. So that could explain why there is minimal venous congestion there.
Exactly, that was the case. 2 sutures were actually making a crease.
Yeah, so if there's an acute bend in the flap, usually only the distal radial forearm has the actual septum attached, because as you go more proximally, it's a free pedicle there. So this is probably the dermal supply which has got some impediment, the dermal return. That's how this part of the flap is getting perfused. So that could explain that. And I 100% agree with Soumya on the case number 3. The inside part is not going to work, and you have to go in early and debride that and put another pec major or something else. But there's a fact to this designing. Always my principle has been take the most robust part of the flap intraorally, because you have to seal off any oro neck fistula. So wherever the perforator is, the skin closer to the perforator, this is a large ALT, the skin closer to the perforator, you take it intraorally, because you know its vascularity will not be bad. And then use the distal skin to cover outside, because an external skin defect is easier to reconstruct with a pec major rather than a DP or a supraclavicular rather than the intraoral defect. So I would design the flap in such a way and use part of the flap which was closer to the perforator for the intraoral inset and suturing, and then the external part can be the distal part of the flap. That's how I always plan the ALT, because I don't want the distal part of the flap to go inside where the vascularity can be compromised, especially with aggressive deepithelialization. So that's how I would design the ALT for bipedal defects.
That's a great point, Deepak. I think that you want your most robust part of the flap to be intraoral, so at least that part survives, and you can actually cover it with another flap if required from the outer side. At least you will be having a partial flap, half of the flap with you, which is the most needed kind of part.
This applies for ALT, pec major, any flap where the most robust and vascular part of the flap should go intraorally.
Right. Dr. Sandeep, you would like to add something?
Well, I would suggest that all the 3 cases need some action. First one needs to look at the tight sutures, take out the kink that is there, and also do some scratching on the part which is congested so as to do a phenomena. I would say multiple incisions with a needle or like 11 number blade, and then on that, so that at least you have taken care of the initial condition and so it doesn't spread further. Second and third both need exploration. Second may not be able to survive, and even in the third case, because it's a longer duration free flap, which is almost the 8th day that these things are happening, there is still a chance that we are able to see there is something wrong with the anastomosis, and we may be able to do something. I would not be totally agreeing that this is 100% a failed flap, because if the monitoring is still happening, say 4 times or 5 times a day, you would have caught it within say 6 to 8 hours.
Okay. So I think very good inputs by Dr. Sandeep on all the 3 flaps. And Dr. Prabha, will you like to add something to all the discussions? Dr. Prabha? Dr. Subbu, will you like to add something else?
Prabha, you need to unmute yourself.
Is Prabha coming in?
Prabha,
Yes.
ma'am?
Yeah.
Yeah, you need to unmute yourself. Yes.
Yeah. See, the first case, as Deepak has said, there is an acute fold there. So there is agreement on the first case, and the second you need to explore. The second exploration, maybe looking at it, is slightly delayed exploration because already the flap is too dark. This, I mean, explore, and maybe you'll have to be prepared for some alternative flap in that case. Case 3, I think whether this is a deepithelialized flap which is folded or whether it is a chimeric flap, you have two perforators and separated and sutured it. That we don't know.
It is deepithelialized.
It's deepithelialized. Then, like Deepak has said, anytime you're putting in the composite flap for lining and cover, you have to, your internal lining should be sound, because very difficult to go if your lining goes bad. Because it's easier to put any flap outside. So the safest, the best part of the flap should go intraorally, and then the distal part which is deepithelialized to come out. This could be, I don't know how it has happened, whether it is inside out or outside in. But the inner paddle doesn't look good. The outer, I am not seeing the whole picture. The inner flap is dicey, may result in, so waiting for a long time will have an OC which is going down into the neck. So I think you need to explore, see how it is. If the outer skin paddle is with the proximal end of the flap, you may be able to still salvage it, take out the inner part and put something inside. You need to explore, because waiting is not going to really solve, because patchy intake inside is always a troublesome thing. It will always end up in an OC, and you will always have a problem and a secondary thrombosis, and you lose the whole flap in any case. So you need to explore flap 2, and you need to see the flap, you need to explore the flap, and in case 3 also.
Dr. Iyer?
Agree, for flap 1, everybody is quite clear. Flap 2, the chances of salvage is remote. Still, I will explore. And as Prabha said, we'll be ready for a plan B also, if needed. Because it's a 4th-day congestion like this. And it would have been there for some time. So your chances of getting it right, even if you're getting it right, it will rethrombose. Flap 3 is the issue. Here, I would agree to the general thing which Deepak and Prabha said about the, the healthier side inside, because that is more important. Now here the problem is, if you debride it, you are sure to damage the vascularity of the other one. You will kill the other one. If you don't debride it, you have a chance of necrosis. You will have to. But I would personally wait for some more time, so that at least you can debride it in a safer way and then cover it. Even if you debride it today, there will be a defect, and the outer paddle also might go because of your whole process of debridement and putting something there. Putting something there with a paddle like this outside is going to be extremely difficult. So my bet would be I would have waited for some more time, thinking that ultimately I will have a plan B of, if everything goes, I will have to do something.
Do you agree with Dhanush's comment that he will remove sutures and decompress the flap?
Yes, I would. I would.
Yes.
I would, but I would remove the sutures on the top part, so that
Yes, sir.
the chances of fluid seeping in is also less. But again, then you have to look at it. Where is it deepithelized? I'm sure the deepithelization would be in the cheek, that labial side rather than anywhere.
Yes.
So deepithelization there doesn't help too much. Still, I would do it in that entire upper half.
Okay. Any of you, while waiting and watching and not exploring the neck in case scenario 1 and 3, will like other investigation like Doppler, anything to substantiate your waiting period or to support, or just clinical?
Clinical.
Mainly clinical.
Anybody will agree or disagree, or anything else?
if you were monitoring the ALT, the larger ALT, the case 3, with a Doppler which you have actually marked there, and the perforator is still working, then the point is that we have to see if there is an hematoma only that is causing this problem, or it is the whole flap which is having a problem from its root. So if we have that thing confirmed by the previous monitoring, the way we have been doing it, then definitely there is a case to see if there is an hematoma there. But if that has not been done, and this is something which we are only monitoring by doing the scratch test, then I would say the issue would be that this flap is failing more on the inside and less on the outside, and it's based on the same perforator, but ultimately it is coming from the same root. So something has to be there, whether there is a thrombosis over there or a pressure in the neck, one has to rule that out, because the only chance we have for saving this flap would be to do an exploration, if we have a chance.
So just a point on the inner side, before, like, I would give a thorough cleaning of the oral cavity, and then I would do a pinprick test. And if the pinprick test still is bleeding bright, I think it is a more reason to wait and watch. But if there is any collection, definitely the sutures have to be opened and opened up. The sutures have to be opened up.
Right. So same thing was done here, and we actually released some sutures in case A, and we allowed the flap to breathe a bit, relax a bit, and the color definitely changed. No doubt, flap 2 we had to take inside. There was an extensive thrombosis and edema inside the flap. We had to debride it, and we had to do another flap. In case 3, we removed the stitches of the outer side. We applied saline dressing to that, and we waited. And slowly, the inner part also slowly regained the vascularity. Though the epidermis peeled off, the dermis remained there. And after around a week or 10 days, we had both inner and outer pedal, which were good in vascularity. But the outer pedal required a bit of 1 week or more to be resutured because we had to allow it to drain the edema. But we were able to salvage the flap 3 also with conservative management. One thing we added to it, which we do here in our institute, and we are kind of right now monitoring our data also for that, is that for flap 1 and flap 3, we did a color Doppler of neck vessels. And we found that my radiologist was able to trace the vessels up to the flap, and he was even able to do that intraoral Doppler of flap 1 and flap 1 also. And he was confident that there was a biphasic flow in the artery and the vein was also draining, which gave us more heart to rate for even flap 3 and flap 1. Though we don't have data at right now which are mature, but this is something else which we have added to our armamentarium in that. I would like your comments.
So that means the reason for the third flap to have this complication was the acute turn that happened between the two paddles, which were more robust than actually would have warranted.
Right.
And so that congestion was basically within the flap itself, not into its circulation.
Not into the circulation, exactly.
That flap could have been left little. I would say don't complete the inset at that point of time when you're doing the initial inset.
It was an excellent point you actually made in your presentation, that if you feel that your external inset is going to actually compress the flap, don't do the external inset, delay it a bit. I think that's a very good point which you mentioned in your presentation. So again, the same book, Way and Madini, they enumerated the causes of flap failures. There are reversible causes and irreversible causes. So we have to brainstorm that what is the problem with the flap failure, you know, and if there are reversible causes, are we able to actually address those causes and go ahead and do something about that? At the same time, they have mentioned very good points when you are going for re-exploration. You know, whenever we do some flap and whenever there is a problem, the knee-jerk reaction of many of the reconstructive surgeons is to go inside and explore. but we don't know what to do. You know, we don't have an algorithm for exploration. We don't have a backup plan. So Wei and Mardini actually mentioned 13 points, not less than 13, not more than 13. And I would like to tell those 13 steps is that first you need to recognize the problem. You need to recognize that there is a problem there and you have to diagnose the problem. You have to see that there are any external effects or not, like compression, dressing, just like in the flap 3, it might have been a tight suture. You have to have a definite decision for imperative surgical intervention. You have to have your entire team in. You have to inform the patient and the family of the problem and the need of surgical intervention. We all know that when you explain the patient is going for the pre-flap for any reconstructive surgeries, it is very imperative to tell the patient that there are chances that there may be a re-exploration, you might need a new flap, and you have to counsel the patient accordingly. But when the situation comes again, you have to be very careful in explaining to the patient also. And no doubt you have to explain the consent also in explicit way that you may need a new flap treatment, etc. You have to prepare your operation staff also, because usually the fails at 10 o'clock or 11 o'clock in night, no one will accept you. And you have to actually have the microscope, your instruments, everything there. You have to do a preoperative workup. You may require blood or other products if there is an hematoma or there is a lot of bleeding. You have to have expedient transport and preparation of the patient. As Deepak rightly said, that there are golden hours of flap salvage. Beyond that, there will be impossible to salvage the flap. So that is very important. Sometimes what happens that in institutes where there are more than one plastic or reconstructive surgeons, the surgeon who has done the flap knows every bit about the flap. You know where the perforator is, where the kink might be, by doing what you can actually salvage the flap. So the one who is exploring should communicate with the person who has done the flap, and that can be really useful. And then comes the operative intervention. So 13th step is the operative intervention, and you have the 12 steps. I think if you go through all these steps religiously, your salvage rates will definitely improve. So as we discussed, we were able to salvage 2 flaps. Now, the next case which we are going to discuss is of a 65-year-old female patient where we did a wide excision of buccal mucosa and a marginal mandibulectomy and neck dissection. And the defect was reconstructed with an ALT flap. And then the patient was doing good, great. But then at 8th post-op day, this event happened. There was a sudden edema of the flap and as well as the cheek skin also. And as you can see that there was a kind of skin changes in the outer skin also. If you see, the flap is still pink inside, but it is edematous. Whenever you are scratching on the flap, there is an oozing of edema coming out of the flap, and the fresh blood is also coming out. So my question to again Akshay, how you will manage this patient? She is an old lady, 8th post-op day. You have a dicey flap in your hand, and what you will do, and what is the problem, and how you will rectify it?
Okay, so in the pinprick, it was bleeding bright, but with the amount of little serous fluid.
Yeah.
And there was no signs of infection. The skin was, there was no rise of temperature. So in this scenario, I would get an ultrasound of the neck.
Okay.
I would not hurry up to take the patient to the operating theater. So I would get an ultrasound of the neck. I would check the hemoglobin. And then if there is no hematoma, if there is a seroma or a hematoma, I would definitely take the patient to the theater and open up and drain the hematoma. I wouldn't touch the anastomosis. I would just drain the hematoma and then wait and watch.
Okay, so we did ultrasound of the flap. There was no hematoma. There was hardly 10 cc collection in the neck and lateral to the flap. But our sonologist said that there is a lot of edema inside the flap. Soumya, what you will do if there is a lot of edema in the flap, no hematoma, and still there is an puffy kind of a flap. It's still bleeding.
I would suggest close monitoring of the flap to be resumed again, to check consecutive, like half hourly, or then if it's okay, then you keep increasing the time period, and you just to notice whether the change in color of the bleed rather than the bleed itself. So if it looks like it's getting progressively congested, then do something about opening up the neck and releasing whatever collection there is. And with regards to ultrasound, this is something that Prabha madam would usually say, that when we send our patients to the ultrasound facility, the pressure with which they would actually do the test, may at times compromise your anastomosis with the friction rather than the pressure. So yeah, I would like to see what is happening rather than rely on an investigation.
Okay.
With
Soumya,
close monitoring.
Soumya, a very good point you have said that the sonologists, the sonologists are usually trained to compress their frog and to damage your vessels more than what is actually necessary. But at the same time, I would like to add that you need to teach your sonologist how to behave with your flap. So we make it sure that every time when my patient goes to sonography or Doppler for the flap, one of the person who was inside the OT, my fellow or myself, goes with the patient and asks the sonologist to look at the place where we are actually having the vessels or where we are actually having the problem. And fortunately, my sonologists are now listening to me. They are kind of trained, and they are kind of helping us out. I will like to add to this scenario that with ultrasonology, we did a Doppler also of the flap vessels. Interestingly, the flap vessels, that is the artery of the flap, was fine. It was pulsating nicely with a biphasic flow. It was stressed up to the perforator, generation of the perforator from the cheek. But my sonologist said that there is no vein. Vein is collapsed. There is no thrombosis in vein categorically, and the vein is entirely collapsed. That's what he added to the thing, except the edema. Now, in this case scenario, Deepak, will you like to do anything else?
I have absolutely no idea, because I have never encountered such a specific problem where there's so much of edema within the flap, that too an intraoral flap. So the sonologist said that the vein is not flowing, is it?
Yes, vein is collapsed. There is no thrombosis in vein, but vein is collapsed. Most probably because of the edema compressing the vein.
This is an ALT flap, correct?
Yes, this is an ALT flap.
So
the mandible is intact.
Sorry?
Mandible is intact. We did a marginal.
So where is the perforator of this flap?
That is in the dead center of the flap.
So would you think that if you open any anti-gravity sutures, you might release the compression between the cheek and the... Is the bulk of the cheek because of the flap, or is it because of the edema?
No, it was initially not because of the flap, but it was kind of soft and supple. Though it was an ALT, there was a bit of the bulk. The lady was having fat inside the flap.
Okay.
But it actually increased in last 2 days.
You're sure it's not fat necrosis or anything like that?
We are not sure right now. We have not opened it up.
I would think that we can try removing some anti-gravity sutures in the oral cavity.
Right.
Or if you're suspecting this to be lymphedema, I don't know how much manual compression would help, because already the vein is collapsed. And by you manipulating or trying some massage or something, it would make it worse. If the vein isn't flowing, I would like to go back into the neck and see what it is, because it's ultimately going to cause the flap to die, if that's what you're saying.
Okay. So this is what we did. We opened up the neck.
Yeah.
We opened entire neck sutures, and and there was a lot of edema fluid that was oozing from the neck. We were getting almost 8 to 10 pads kind of soaking wet with the edema fluid, and we
You
had
sure it's edema fluid and it's not saliva?
yeah, it was edema fluid only. It was
Okay.
edema fluid.
Okay.
Because the neck, because it was so tight, I don't think so anything from intraoral to can go extraorally, because such a tightness of the flap.
Yeah.
And the of the flap was till date fine. All the suture line was good, but there was a lot of edema which was coming out, and we placed this corrugated drain there lateral to the flap, because there was no other place where we could have.
Dr. Dushan, what was done for the parotid duct?
For the parotid duct, yeah, parotid duct was tied in this case.
You have ligated the duct.
Yeah, ligated the duct.
Sometimes they can be leaked from the parotid tail area also. But
yes, that can be leaked. I think that's a good point.
Dushan, do you remember the case we did, the fibula for maxilla, where
yeah,
severe parotitis?
Yeah, that compressed the vein.
That compressed the vein, and I had done it to superficial temporal artery and vein, and then you had to redo it with a vein graft to the neck. You remember that case?
Yes, I do remember it.
So I guess we have to keep parotid pathology also in mind when you see such, like, that also has to be kept in mind to rule out any salivary collection or parotitis. But I would have opened the neck in this case purely because the vein wasn't showing any return.
Exactly.
The vein blocked at the upper extremity. That's why it was not distally filling up. The compression there higher up.
The compression was in entire cheek flap. So entire cheek was kind of compressing it. There was medially there was mandible, laterally there was tight skin.
Yes.
It was kind of a compartment syndrome laterally to the flap.
It was, artery was not as yet compressed because the pressure may not be adequate for that.
Yes. So it was kind of timely that we released it. And when we released it, things improved. And slowly down the line, that also improved. As you can see.
Can I ask you a question?
Yeah.
Pedicle was tunnel medial to the mandible or lateral to the mandible?
Lateral to the mandible.
Lateral to the mandible.
Yes, it was lateral to the mandible.
So there's not much of a floor of mouth defect.
Yes, exactly.
Okay.
So what happens, Deepak, usually is that when the flap is bulky and when you are going to put it intraorally, what happens that your suture line to the floor mouth and upper alveolus is there, and then after 2 or 3 centimeters of thickness, your pedicle starts. So if you take the pedicle medially on the mandible, there will be a kink.
Correct.
So the normal lie is usually lateral to the mandible.
Yeah, and with ALT thickness, so it will have its own padding like that.
Exactly.
Yeah, try and thin the ALT as much as possible. I guess that is because a lot of this edema is because of the fat edema rather than the skin edema. So
yeah, it's a bulky flap.
Right. So I think debulking of the flap can definitely help in such scenarios preoperatively. So flap fashioning before your inset is also very important. So we were able to salvage the flap, but this is what happened at day 20. The skin of the cheek gave away, and there was kind of an unhealthy flap, unhealthy soft tissue under the skin of the cheek. Everything else was healing fine, and one day there was a perforation in the skin, and now there is a kind of an unhealthy tissue at that portion. Now the lady is having an immediate requirement of the radiation also. We were thinking that if everything is fine, we will either suture the neck or we will put an STG in the neck skin, but now we are getting another problem with the cheek. So any suggestions how we can heal this wound of the chin faster to start RT or something?
You're asking me?
Yeah, Dr. Subbu.
Yes, this question. I always felt that there is an infective cause. There's an impending sepsis or cellulitis, I would say. Sorry, apologies. Cellulitis in that first element. If you see the neck wound, it was not a clean wound. It was yellowish. It was not, it was early sort of thing. Why did this skin necrosis occur? It was the edema would have been the impending cellulitis. Did you treat it with antibiotics? I'm sure you would have treated it.
Yes.
So the release of the skin to decrease the edema along with the antibiotics would have played the trick. Whereas this skin necrosis would have been the end arthritis at that time when it occurred, which has resulted in this skin necrosis. So don't forget cellulitis leading to this. And then the treatment is same what you did. You will have to release. I would have maybe released a bit intraorally also, as Deepak suggested, anti-gravity, so that the entire thing. Maybe I would have put my finger under that tunnel and make sure there is nothing collected there before we do this.
Yeah.
This is a big problem now. Is can you show me the picture? Is there any other picture which shows the entire lateral side of the face?
Not right now, but this is only which I have right now.
Now it is going deep into the flap, is it?
It is around 1 centimeter defect with a bit of undermining around the skin, around 1 to 1.5 centimeter.
And it's under the zygoma. It's just under the zygoma.
Yeah, this is the zygoma, and here there is kind of undermining under the skin, and this is the area which is around 1 centimeter deep.
Yeah, your next skin will come by closure. I am sure you can mobilize and close or put a graft, whatever is that. The other one, the vascularity will be. How is the pliability of the preauricular skin?
Not much, sir.
Not much. It's going to be a problem. Even if you mobilize a Limburg type of flap or whatever is that. Or the only way I would say is that you can take your superficial temporal artery was fine, no?
Yes, it was fine.
So maybe a superficial temporal facial flap and then fill it and then put a graft on that. Might be one option. Because it is far away, nothing is going to happen.
Right. Dr.
You mean like a freaky
will be too much for it.
So you mean like
Pardon?
a freaky flap?
No, pedicle flap.
No, I'm saying pedicle flap, like the design like a freaky flap.
No. I would put a superior incision into the temporal fossa and then take the entire superficial temporal fascia. STF, and
it's
then
not a skin flap, sir.
No.
Yeah,
I'll put a graft.
Okay.
Dr. Sir, you would like to add something?
Sorry?
Dr. Sir, yeah.
Maybe we use a VAC dressing.
Yeah, why not?
You don't have time. That's the only problem. VAC will take at least.
It's 10th day only. It is 10th day.
3 weeks.
This is.
Yeah, you can try. See, if it is 10 days, you can try. See, you wouldn't like to operate. Your only idea is to look at the radiation.
See, even if you have to do another flap, the edges are still not good enough to receive that flap. That flap itself can get infected. So why not limit it to by doing something only in the local area? And as such, we are doing a grafting at the lower edge. Once we have seen that the tension is relieved, that
see, I see there is no contraindication to VAC in this to try initially. There is no problem because it's away from the pedicle. There's no vascular issues there. So you can very well try VAC for a week and see how it behaves.
Right.
And then get it filled.
Sir, can I ask some questions, sir?
Yes, sir. Yes.
Sir, I want to ask to Prabha Madam and Subramanian Maya, sir. Sir, Dusyan sir already told that this wound around 2 centimeter. Can we close it primarily as because we can see the over the cheek there is a little bit skin is there.
You are most welcome to do it if it is mobile. Nobody would put it there.
If the skin is pliable, you can close that like an elliptical excision. But this skin is not yet settled down. No? It must be very indurated. To mobilize that, you may invite little more problems. So maybe it is just 10th day. So you can debride and wait and do a VAC and then take a call because your radiation has to start after 6 weeks. And after about 8-10 days, it doesn't improve, then we'll have an option of shifting something local and then putting a graft or shifting an islanded small flap from there, which you can close primarily all grafted.
Right.
Superficial temporal based small flap.
Right.
Thank you, ma'am.
So this is the third case.
What did you do for that?
This is the current situation, sir.
Oh, is it?
You have been clever. You've been clever.
See, it's only 10th day, so you have enough time. So by that time, I think maybe what Dhanush said, that will work.
That's why Dhanush was very itchy to close it. So okay, so the next case is of a central arch alveolus patient where we did a central arch segmental mandibulectomy and bilateral neck dissection, and we reconstructed the patient with fibula, free fibula osteocutaneous flap. And he's a 55-year-old gentleman, a bulky one. And this is what we got at around 5th day. What happened here is that the patient was doing fine, but suddenly there was an infection at floor mouth. And there was a significant pus discharge from the floor mouth. And that pus discharge actually resulted in a fistula, orocutaneous fistula, from the same side where we did neck anastomosis. And the skin started getting problem. So after, what we did, we opened the neck, we drained the fistula, we placed an corrugated drain inside the neck. Everything was coming out. The wound started getting less and less infected. But as you can see, the skin of the periphery had a bit of vascularity, kind of, but inner part of the skin, outer skin was good, kind of at the margin, but the inner skin started getting necrosed.
This is gone.
So what to do with this flap? Do you go full-fledged inside, debride everything, come out? You just do partial debridement, wait and watch how the flap behaves, because it's a precious flap, a central arch fibula in a hefty man, and till date the half part of the skin is kind of bleeding well, and we have kind of taken some control of the inflammation and pus discharge. Dr. Soumya again.
Okay. My first and foremost concern with any free fibula flap in which the skin paddle is giving an issue is contamination of the plate. So even if this flap were to survive, if there is a biofilm that gets formed over the hardware, if not now, post radiation, sometime all that is going to give way and we're going to have, if not immediate, but delayed problems. This flap, the way that it definitely looks like the inner paddle is gone. A partial inner paddle survival in a free fibula flap is never a good idea. So if the first thing would be to take this patient into the OT, take down the skin paddle, check if the bone is bleeding, and if that's fine, give a thorough wash, all that. And if possible, if this, you mentioned that the patient is hefty, so probably taking a thin pliable radial forearm flap and securing the inner lining would be the best case scenario, if that's possible.
Right. Unfortunately, we explained same to the patient, but patient said that no, I don't want to go for another surgery. And we kind of had no choice but to debride the flap inside the ICU. He was not even ready to go inside the operation theater, and we had to debride the flap. And we did serial debridements of the flap, and this is what has happened after that. He has started having granulation from the floor mouth side. As you can see in the second, there is some skin here, which is also looking good. But as feared, there is a fibula here and there is a partially exposed hardware here in this patient. So my questions to Dr. Deepak here is that how to identify that if the skin goes, it is only the skin loss and not the bone loss. Is it only you go inside the OT and then you know that your bone is viable with all the full-fledged kind of preparation that you have to use a next bone flap, or any other investigations or anything else which can say that your bone is viable? How to deal with that scenario?
Usually the skin is a surrogate marker for bone viability. That's how we normally monitor these flaps. But when the skin goes, the only thing that you can see is rub the bone and see if the bone is bleeding. But I doubt that would have been possible in this case after so many days, because there will be a lot of fibrin and slough around the bone. And for me, any bone exposure means devitalized bone. ISR also will have some thoughts on this. But for me, any exposed bone is devitalized bone, and any exposed hardware and exposed bone means it's devitalized. That is my take on it. So, we have to plan for another bone flap if possible, forgetting this person's circumstances. But I don't think this will be a viable flap in the long run, especially if he's going to receive radiation and all those things. This is going to show problems sooner rather than later.
Yeah, so he's already having this on the 21st day. He is T4AN0. He will definitely require radiation. But with this scenario, it will be really dangerous to even send him to the radiation oncologist even.
Yeah, but then what are we waiting for? Because any exposed bone after some time becomes devitalized. And
Exactly.
the pedicle behind that bone also was bathed in saliva for some time and bathed with dead tissue and all that. So, and we don't know if this part of the bone is surviving based on the pedicle attachments or just the periosteal attachments. Because, the fibula, after a certain point, when you do the osteotomies, it's only the periosteum that connects the distal most segment and the proximal segment. So I would think that this bone is non-viable, and you have to plan for something else.
Anything like bone scan or something helps in this scenario?
Yes, bone scan will help you. This 21 days, na?
Yeah, 21
That
days.
will show you. But you'll have to really draw the picture and ask them what segment to be seen. That will definitely show it. Not initially for first 5-6 days, everything is like a hotspot. But now it's almost 3 weeks. So
Yes.
bone scan will show whether the bone is viable or not.
Okay. So
Or you have to, in any case, you have to close it. So you have to open it and see, you will be able to judge that time also.
So will you like to use any local flaps like bilateral nasolabial or something to cover this central defect, Dr. Sandeep?
It is possible that if you are pretty sure that the bone is viable and
Yes.
it has been there for almost 3 weeks,
right?
Maybe there is a good chance that you remove the hardware and just cover it with the nasolabial flap, bilateral nasolabial flaps. It would be unstable because the fractures are not healed by that time. But that would be the only good chance for this patient to have something viable and covered with a vascular tissue, which ultimately would heal and would take up some adjuvant therapy. Because if we leave behind the hardware and do the reconstruction, maybe through radiotherapy itself, it's going to show exudance of pus and seroma and other things. That would be my take on this, to come out with as little as problems that this patient would have financially and otherwise with respect to time and money.
Okay, so you advise to remove hardware and do some corrective surgery, kind of local flap or nasolabial or something. Yeah. Amit, you want to add something to it?
Most of the points are already discussed, but bone scan on the 21 day, as ma'am said, that we have been doing bone scan on the long follow-up cases in which the skin pedal is surviving and we want to know the viability of the bone. So bone scan is an option, but hardware exposure, I think we need to remove it because that is going to create problem during radiation itself or after radiation. Any point of time is going to create problem.
Okay, so I think we will have to explain the patient about the scenarios because he needs to.
Dushyant, can
I add something?
Can I add something?
Yes, sir. Yes, sir.
See, to me, the issues are, one is the question you asked, whether the bone is viable or not. There is a chance that it is viable because the skin paddle part is working. But if it remains like this, it will become unviable. The chance that the skin paddle is getting blood supply from the periphery and is bleeding is also there, but highly unlikely at this in this number of days. So if it is viable, can I cover it? And my priority would be to not to delay the radiation, whatever is that, and prevent the anti-gum deformity to the extent is possible and reconstruct that central mandibular segment later on if possible. So if the bone is viable, I would like to put a soft tissue covering to that and continue with the radiation, hoping that it might survive. It might not, but then you have time. You can reconstruct it later after 6 months or whatever is that. The mandibular arch is maintained then. So you need to replace it with a good vascular tissue. Maintaining the arch is very, very important. I will disagree to what Sandeep said, but I wouldn't even remove the plate. If the bone is unviable, I would retain the plate and put a pectoralis major there and continue with the radiation. And if the patient is reluctant, they are quite, whatever is that, leave it for the like that. Let it be exposed. When it is exposed, you correct it whatever is possible. Otherwise, plan for a corrective surgery after 6 months, 1 year, but the arch is maintained and your urgency for radiation is over, and you know that the patient is going to survive or not. So you buy time like that. I would put my bet safely in this way, looking at.
Right, sir.
I wanted IS sir to say about the plate and PMMC from his mouth. So that's
No. See, if you look at it, if you
no,
look at
right,
it,
sir. I wanted them to know that. That's all, because the plate is a squeezer. It helps the segments in place when we go back and put the new fibula in also.
You don't know what is going to see in 6 months.
Correct, sir.
Whether the patient is alive, patient is this thing, but you are saving that mandibular position for if something can be done at that time.
Right. Dr. Nitin, Dr. Ashay, are there any other questions which we want to take right now? Or we should go to another case.
Sir, please continue with the case. The panelists are answering the questions in the chat box.
Fine. Great.
You can continue with the case.
Great. So I think this is one of the case which Dr. Sandeep was kind enough to share with us. It's an 8-year-old male patient with no comorbidities, and there is a central arch, floor mouth, and neck skin defect, and was reconstructed with free fibula, multiple forward-based skin paddles. He was kind enough to share this images with me also. As you can rightly see here, there were multiple skin pedals here at the tongue, at the floor mouth, at gingivolabial sulcus. There was outer skin also, which was involved, which was removed. And I think Sir deepithelialized the skin pedal, which was a robust perforator-based skin pedal. And then it was sutured to the outer place. Patient was fine, drains were removed, patient went home, and suddenly the patient comes on day 15th with a swollen flap intraorally, and it's kind of swollen edematous and pale flap, and it is not bleeding even on the scratch. On the day 15th, it's very delayed kind of thing. So my question to Dr. Iyer again, how you will take up this situation? It's in free fibula where there is no bleed from the skin.
So it's failed. We don't do the bone scan, but I would I will take the advice from what Prabha and Amit was saying, that I would like to see the viability of the bone.
To add to it, the patient was an airline pilot. Yes, if I'm right, Sandeep sir.
Yeah. Yes. All right. See, we don't have to worry about such sort of patients. Only Sandeep has to worry.
He should be on his 12th day also. He was okay till day 12. Not that there was a gap of a week between his visit again. So between
was the Doppler working? Do you think that the flap has totally failed?
Yes, on the skin side, yes.
Bone, was the vessel working?
That's something which I'll tell you later on.
So I know I would Doppler it if you can get a good Doppler, or the bone viability by a bone scan is viable. I would assume that the skin paddle is gone, and then you take all the things to cover it quickly. I would say quickly in the sense that, see, it's 2 weeks anyway. So you can do a second free flap with a radial forearm, whatever is said. I would choose a very safe flap, like a radial forearm, to remove the entire thing, cover it up, and use the same radial forearm skin for the external cover also. I wouldn't think of any other flap, because, to the opposite side, Radial forearm is the safest in that. I wouldn't look at pectoralis major or anything in this case because of his profession, all those things. No, it doesn't suit also. So all depends upon intraoperatively, I find the bone viable or not. If the bone is viable, I'll change the skin paddle to a radial forearm. If the bone is not viable, I would go for a second free flap.
Second fibula.
I think, Sandeep sir, you can take them ahead of your exploration, I think.
Yeah, actually, if you take the first photograph, just show the first photograph. If this is something which you can look at, this dent that we see here.
Yeah.
So I also had to look it back and then realize that there was something happening which maybe I missed. And this was exactly the place from where the perforator was coming.
This is the osteotomy site, is it?
And also, yes. And so this was actually the site which his teeth was hitting. And finally, we lost this flap because everything had settled. He had gone home and he had started oral.
Chewed on it.
So actually, once he started eating and drinking, his perforator gave way and everything went haywire. And to my, I think this is almost the first case that I would have had that I had to take down this flap on the 15th day. And to my surprise, the artery was still intact. It was bleeding. And the venous side of the circulation of the flap had nothing. So as it would have happened, the return from the perforator side was not there because that indentation actually almost killed the perforator there. The bone was bleeding at places. Definitely in the central area, it was bleeding at places, but the periphery still was not. So I took out the whole flap and I did exactly what Dr. Iyer said about the first case, the initial case that Dushyant was discussing about. The one case we discussed prior to this. Retained the plate and gave him a pec major flap because what he required was a huge volume of tissue in the floor of the mouth. It was actually almost a pull-through surgery, and the flap actually went under the hardware plate and then came out in the mouth and out over the plate and outside over the neck. So that was how the whole reconstruction was done.
Bone was viable.
Bone was not viable in the entirety. The central segment of the bone did not show any circulation. And that was actually when I was cutting at the flap, I was quite skeptical. If this bone was there, then it would have made a case for giving another radial forearm flap or any cover on that.
Yeah.
But because of the fact that there was an impingement on the circulation of the vessel exactly in the center, it was also causing problem for the distal bone in that very area.
So I think it was mechanical compression.
But why not, sir, why you did not do second fibula?
Patient did not agree because he needed his legs also.
He needed to put brakes on his athlete.
Yeah. For him, he said, if you take a pec major, I can maybe still be fit enough to have some activity.
Right.
But if you take both the bones, I may not be fit to be continuing as an airline pilot. And I have followed this patient. He was an international patient. He was from, I think he was flying Air Romania. And this patient, after we did a pec major, I followed him for almost 2 years. He did well. Everything is fine. And after that, since last almost 8 months or so, I have not seen him. He used to be there coming for regular follow-ups.
So let's move again to the next case. So I did some literature search about the late free flap failures in head and neck. And so there are some systemic reviews also. And all of them, as you all have rightly said, there are usually common reasons of failure like abscess, infection, and vascular compromises, most probably due to some edema or some mechanical compression to the flaps. So in all of the series, almost this has come unanimously as the causes of late flap failure. Now let's go ahead with the one more problem of head and neck. Usually our head and neck wounds are clean or not maximally clean contaminated wound, and we very rarely come again very severe sepsis or very severe necrosis. But I would like to share with you one of the very worst kind of necrosis and infection which we had. He is a patient, 42-year-old male, who had through and through defect in the cheek, and kind of a lean and thin patient, and we did PMMC flap in him, bilobe PMMC flap. The skin of the neck from the day 3 started giving some discoloration, and at day 5 we had this fulminant kind of necrosis in the flap, around the skin area, and even in the chest area. And as you can see, it's kind of a very bad, ugly looking picture. Dr. Soumya, how you will handle this situation? What you will suspect? What you will do?
Looks like some form of cellulitis. What is the status of the intraoral paddle of the flap?
Pedal is good. With God's grace, the pedal is good.
Okay. So I think this picture, I mean, it looks worse than what it actually will be. And it could be a wait and watch strategy that can be applied, where you give good antibiotic coverage, possibly do some local debridement, and just give it some time for granulation tissue to reappear, and then this chest wound can be managed with just a skin graft at a later date.
Dhanusha, you would like to add something? Dr. Dhanusha?
Yes, sir.
Yeah, you would like to add anything to this?
Sir, yes, by looking this scenario, this I would go through the immediate debridement and remove all the sutures and everything, and debris and necrotic tissue, and make the wound is clean, and followed by the oral medication, and improve the general condition of the patient. As over the neck and the flap side, same. I would like to go to for the debridement and remove all sutures, starting from the upper side, cranial side, gradually to goes to down, and remove all necrotic tissue, and then thorough debridement actually required for this patient. Then only when infective foci is there anywhere inside the body, they definitely will fulminate again, and then which maybe leads to a cellulitis, sepsis and sepsis type of condition. So this is first step to do this.
So as you both rightly said that this is not one of the common scenarios in head and neck.
Dushan?
Yes, Deepak. Yeah, please.
Why is the chest wound necrosing beyond the suture line? Is it some sort of fasciitis or?
Yes, sort of necrosing fasciitis. The picture looks like that.
Yes.
Because
Diabetic status?
Yeah, his general like diabetes and
he has no other comorbidities. He is fit and fine.
This is so rare, no? Because
very rare, very rare.
Not communicating with the oral cavity. What is the reason? Was it a a resistant bacteria or MRSA sort of type?
Maybe MRSA.
Yeah. So let me take you through it. So we did some literature search, and there are a few cases of necrotizing fasciitis in literature, and they do behave bad. They say that usually E. coli, Proteus, or gram-negative streptococci are the culprits. Patient usually can have some immunocompromised status, diabetes mellitus, and this will require actually a very aggressive management, because many a times we don't come through these patients, and we kind of don't foresee it. So what they say that, and what we did is we did swab of this patient, and there was a heavy growth of E. coli in all the wound. And rightly said, we did a thorough debridement. We had around 4 or 5 procedures in this patient with debridement, and ultimately saline dressing, and ultimately a healthy granulating wound, and around 3 sessions, I think 3 sessions of skin grafting, and ultimately the wound started healing.
Even
And
hyperbaric you can consider if it's a problem.
yeah. So hyperbaric is a good suggestion. We were lucky that the flap survived. You know, flap was kind of floating in between. Sutures were removed from all the side, and with all these adversities, our cemented flap, you know, kind of. I will say that PMMC is sometimes RCC. It doesn't budge even to the infection. So it's
Yes.
But we've had a patient who had rib osteomyelitis after a pec major harvest, exactly like this. Was fasciitis, then it became deeper and deeper, and then we had to debride like part of the rib, and we had to use opposite pec major like how we do for chest wall closures. We had to use the opposite pec major and try and close it. So it's not I guess it's not that uncommon, but we have to be very careful, I guess.
yes. So we have to be very careful. I think
So the neck
one
looks like to be
observation.
neck looks like to be primary closure.
yes.
There's no graft on the neck.
No, it came primarily.
Great.
Question one observation.
Yeah.
It's actually a very huge flap that you have harvested.
Right.
And I would say one small observation that comes from the fact that whenever we take a large paddle and the
Graft.
skin that is actually planned over the pectoral area, we should realize that the most of the skin which is supplied to the chest is the area where the free border of the pec major is there. There we get the maximum supply to the skin overlying that. So if we orient the paddle of the large flaps transversely rather than obliquely, the two things will not correlate to each other. One, the area which is left behind will not become devascularized, and the flap that is taken to the reconstruction site would also have a better supply. That is my observation with all the large flaps that I have done. I find it that if you orient it transversely, and you may go well beyond the anterior axillary line, almost up to 5 to 7 centimeters, they do pretty well even in the large size. And that is to do with the supply that you get from the free border of the pec major muscle.
And Sandeep, so the other important thing is if you keep it transversely, because of the length and breadth ratio, you can take some more of the rectus, the skin on the rectus also.
Yeah.
So it gives you a wider flap also if you need to do that.
So kind of
I think
modification
there
of
must have been some ischemia which actually made the organisms become subservient in that area, and it became a necrotizing fasciitis.
Yes, sir.
The issue was that it was at both the sides, you know, at the neck also, at the chest also.
Okay.
So I think the take-home message is that you have to keep an high index of suspicion. Look for the immunosuppression if there is any. You have to act really fast because it is a rapidly spreading. You know, we waited for 2 days just by doing the dressing, and it actually spreaded a lot. Use culture. If required, use histopathologist. Ask your microbiologist to look for atypical infection and give fast kind of a broad spectrum antibiotics to start with. Hit with the hardest available instrument or available antibiotic you have, and then you downgrade your antibiotics if required according to culture sensitivity. You need to monitor nutritional support of patient also, because patient can go in generalized sepsis also, and that can actually complicate the entire thing. So I think a high index of suspicious and rapid action is required in this kind of flaps or this kind of problems. Donor site morbidity. Deepak has said a lot about this. I think we have a rich donor, and then it gives and gives and gives, and we rip it up, and then we end up like, you know, this beggar kind of a donor. And as we rightly discussed it, you know, Deepak mentioned all the problems which can happen with wound breakdown and skin graft loss and delayed wound healing and all the problems which you can have with this radial forearm flap. When I went to the literature about this donor site morbidity issues in radial forearm free flap, one thing which I really came across is that not only leaving the area open and putting the skin graft is the only problem. Many instances where it happens that you have raised the flap in a bad way. You have actually inflicted injuries while raising the flap to the donor area, and which actually causes a significant part of donor site morbidity. So, Deepak, can you enumerate that what care you should take while you are raising your radial forearm free flap to reduce the morbidity?
So I think the most important thing is to do a suprafascial dissection just until you come to the pericle and preserve not only the paratenon but also some fascia over the paratenon. And you have to be very careful when you're handling the skin over the tendon. So I guess tendon exposure happens when the tendon is bare and doesn't have any paratenon on it. And second is when you're closing, you've got to make sure that there is no bleeding. There is no chance of hematoma formation under, and you have to keep you have to handle the donor site in as a sterile way as possible. You know, many a times you don't remember to change gloves. You don't remember to irrigate the wound bed before you close the wound bed. So you've got to take care of those things. So preserve the fascia above the tendons, do a suprafascial dissection, try to keep the bed dry for the graft to take. Securing the graft not only in the periphery but also in the bed is important. And the graft should be supple. It shouldn't be a very taut graft that is tenting up. And then a bolster dressing or a tie over dressing would help. And the thing is, this is what I've realized, that all these grafts look fine till like the 5th day, 6th day. It's only when the patient start moving the tendons that it tends to shear off. So you've got to, limit in some way their wrist flexion and extension also for some time. So all of these things will, and obviously like systemic factors like diabetes and, poor glycemic control, all of those also contribute to poor graft take. So keep the area clean, wash it well before putting the graft, avoid fascial disruptions, secure your graft properly, and try to limit the movement of the wrist for a few more days after the graft is taken up.
Right, Deepak. Deepak, you will use a very thin graft like split thickness, or you will use a full thickness graft?
I mean, cosmetically, you can use an intermediate thin graft, not a totally thin split skin graft, but you can use an intermediate graft because that cosmetically gives better reasons, but the take rate is going to be less. So a thin skin graft is fine. But you just make sure that the skin graft is secured to the bed. And the most important thing is, I've noticed a lot of the people, you have to put an ulnar gutter splint. An ulnar gutter splint is extension at the wrist and flexion distally. So you have to put an ulnar gutter splint because that is what brings the bed of the forearm to contact with the graft. I've seen a lot of people who put the splint in a neutral position or a flex position. If you try that with your own hand, you'll realize if you keep the slab in the cast in a flex position, there's a tent between the brachioradialis and the bed of the forearm. So you've got to see that, make sure that your slab also is placed properly in the ulnar gutter splint style. So you've got to do that.
Right, Deepak. I think that ulnar gutter splint point is really important. And usually you just give a flat splint and
that will cause a big gap to form between the tendon and the
what we do is we give an volar splint. We want to prevent this movement. So this position is the position that we give a plaster. It's a slab given and then you tie over and then the slab is given up to here. And then you remove it after your first dressing after about 5 to 7 days, and then you can have some sort of a compression over there, like a crepe bandage or a pressure stop.
Yes, ma'am.
So that helps to stabilize it much better. And a totally superficial harvest, and keep the tissues wet all the time because you forget to irrigate the tissues and tissues or paratenonic exposed really dries up.
Any one of you have used expanders before raising the flap or after the flap to close it with skin? Anybody of you has used it?
That will be in a non-malignancy case.
Yeah.
So
has used it?
There's another technique of closing the radial forearm. You can use an ulnar advancement flap. It is actually
but that is for very limited areas, not a very big flap.
If the flap
you can do a sort of a big transposition from the ulnar side, but that is for a very not very big flaps.
It's a very small flap, ma'am.
Very small flaps. Yeah.
So
you can shift it like a rotation flap. You shift it and close it primarily.
Yes, ma'am.
That is it.
Amrita, I
Or
think.
a flap like that.
Shape
I think
Or a flat, longitudinal flap like that.
exactly. This I think
Yes.
Surij had this kind of presentation from Amrita, if I remember right, Deepak.
It
Yes,
has in,
the
it,
shape modified radial forearm.
it has
Yes,
been published recently in Head and
Head
Neck.
and neck. We just
last
this month or last month.
right. So what would be the maximum width you can take with this kind of design?
Whatever you can close primarily by pinching,
Okay.
and then you
2
double the width and calculate the length. That's all.
Usually 2 centimeters.
2 centimeters.
Right. So I think Dhanush, you also kind of use certain techniques for that. Will you like to elaborate on that?
Yes, sir. I would like to say that even though the literature says that the rate of the graft loss is 10 to 12%, but fortunately we have less likely to see the graft loss and 5% in spite of the operating more than 150 radial artery forearm flaps per year. Already Deepak sir already stated that and nicely elaborated all the techniques and debridement followed by the limb elevation and splint. But a very opt question which I have always had in my mind, that can we avoid this type of complication, or if answer is yes, then how? So we decided to work on it, and may I take this opportunity to present to you all that our technique of modified Tromberg flap, which we are employing in the defect of the 8 centimeter into 5 centimeter size of the donor side of the radiograph, and we have been successfully in achieving primary closure of all such defects of flap donor side. This result submitted as an article in IJPS and under process of acceptance. Our main aim or motto is to effort to reduce or eliminate donor side morbidity, which I think improve the quality of life of the patients. So this is my results, which I showed this over here. Primary closure of donor side.
Prabhav, so Dhanush says that he will be able to close around 8 centimeter by 5 centimeter defect with this.
That's the patient.
Yeah, this and I think he has a series of around 20 odd patients now, and it has
Very good.
Very good.
Dushyant, this is almost similar to like a ulnar rotation flap. You know, you go all
Yeah,
the way up. Yeah, exactly. It is
ulnar rotation flap.
Yeah, it is ulnar rotation flap. Rotation flap. The only problem is sometimes if you have a problem with this, you create a much bigger donor site. You know, that is, we had, I think, successful few cases. One failure made us rethink about it. No, I mean, your donor site becomes necrosis of that thing, then you add up the donor site very badly. No, it is good. If you work, it's excellent. And when you look at it, when you raise the flap, you get worried. The whole forearm is raised.
Yeah.
On that thing.
So let us move to the dehiscence and resultant defects that we always don't get all the flaps work fine. You know, they work good intraoperatively, they work good post-operatively also for some time. And then you start having some dehiscence and some portholes, which kind of are troubling. So these are two cases which we have. First case on the left side is of a bilobed pectoralis major flap for an composite defect of mandibulectomy and maxillectomy. Patient was doing well. Patient received radiation. Post-RT there was an dehiscence. On the right side is an ALT flap. Patient was doing good. Patient was having everything fine. And post-RT suddenly you have a gap. Entire flap drops down. And you have this ugly looking defect, which is kind of bothering. So to start with, I think, Amit, can you tell me something that while you are planning your flap, will you take certain measures in planning of your flap that that can kind of take care of these problems?
We need to assess the full defect means for the inner and the outer defect, and the soft tissue required. And even if you are planning for another flap, for such a means high defect, then the local flap is going to be a big challenge. So if you plan for a free flap, then we need to work up for the vessels.
So I think very importantly said that you need to see the dimension of the flap. What usually we do is that we measure the inner measurement, outer measurement. But this type of flap goes way down from in to out, and there is a significant distance which the flap has to travel from intraorally to extraorally. You need to add that dimension to the flap. You need to add extra flap which you may deepithelize and put inside the zygoma. I don't know this things works or not, but at least a smaller flap will cause bigger problems. Dr. Prabha ma'am, can you add to that?
No, the one with the bipartite PMMC, that case, I think already the upper limit for the PMMC is the limit is too high up. It is, I am surprised that it withstood even the radiation if he could finish the radiation. Otherwise, reaching up to zygoma, I think you are expecting a little too much from the PMMC. That may just drag down with the gravity its weight. And this is an unsupported inside, maybe post-RT that has just given way. So you need to have an support. You can't have an depth which is not, the two flaps which are not supporting each other. The outer one is likely to break down. That must be the problem in the, and your intraoral defect may be at the palatal level, your outer defect is at or reaching the zygoma. So there is a differential inset. That is one reason for this case. And for the ALT, I think whenever you are giving a bipartite ALT, somewhere wherever there is a bone, I think you need to hitch it to some tissue over there, make a drill hole and anchor your flap over there. Otherwise, again, same thing, post-RT, the scar will straighten, it will break down. I think that could, and support the depth, what is there, the tissue can be filled up in the cavity. So with the ALT, it is possible.
Yeah. So what happens, what we have seen or what everybody might have experienced is that when you suture the skin is good. And at time when you are taking your ALT, you are tempted to take more muscle, which you will feel inside the infratemporal fossa at the time of inset primarily. But slowly down the line, when the patient receives the radiation, the muscle itself shrinks down.
No, you don't have to take muscle. Your ALT flap itself will have the bulk. You can deepithelize some part and bury that.
Okay, so
that will last longer than any muscle that you will take along.
Exactly. So it is better to put a deepithelized portion of ALT in front of the
because denervated muscle will always atrophy and will just reduce.
Yes, exactly.
And first stage at PMMC, it was too high up a defect, I think.
Right. So we
getting too much from the PMMC.
We aimed the stars and then dropped down. Yeah. Deepak, you would like to add anything else?
I mean, I agree with ma'am said. This anything reaching the zygoma is not a good idea for a pec major. And you can see the ALT, you can use the deepithelialized portion. You can take a large flap and stuff it in and then obliterate all the dead space. And it's not dependent on gravity also. So it removes all the problems that the scar is going to have post-op. And to correct the situation, now I really don't know, because how far is he off after radiation?
So this patient, the first patient, is almost completed radiation. You can see the scabs around still and the red darkness around this one. This patient, the ALT one, is 1.5 years after the radiation. So he is kind of knocking our door every week and says that you were telling that after a year of radiation you will do something, and we don't have answer.
He still has erythema and he still has erythema of the skin.
How is his intraoral situation?
So intraorally, this second patient has a very small fistula.
I mean, this is the near the zygoma. That's the PMMC patient.
Yes.
So how is the intraoral pad behaving?
PMMC patient has good intraoral. Both the patient has good intraoral pedal, but at the palate
Okay.
there is resistance.
Yeah. Then either you require some flap only to cover it to fill it up, or if they are willing, if your prosthetic department is good, they can give some prosthetic shell from outside just for the time being till you're waiting for the reaction to settle down.
Yeah, prosthetic retention, if there is, I don't know how the prosthesis is going to retain here. With adhesive.
See, there's a big cavity there inside.
Yes,
so they
ma'am.
can take that undercut or sort of an adhesive type or something.
Adhesive type.
I mean, for that. Here too, we can, the other one, ALT, I think after some time, if you wait, you may be able to advance that flap or shift something from the forehead or the scalp.
Forehead is probably the option for both, I think. If they've come to surgery. I mean, if the plan is for surgery.
Yeah. The problem is that in this ALT patient, even this external is sacrificed.
Okay.
So
can temporalis be an option here? Just to consider.
Yes,
temporalis muzzle to kind of.
No.
No, the external carotid was taken.
It has lost coronoid also. It is the temporalis is cut. It was an appearance there.
It's maxilla also done, na? Partly. So you must have internal maxillary also.
Yes.
So your temporal muscle supply is gone.
Yes. So superficial temporal is gone. Temporal muscle supply is also gone. We don't have any immediate tissue which we can fix.
So then if you just want to cover it, you can shift an pedicle median forehead flap, a little extended one.
Okay.
Dushan, can I say something?
Yes, sir.
Or the other flap.
Why if this patient has completed 1.5 years or maybe 2 years, this patient we can consider for another ALT flap. We can.
You can.
Yeah,
you can consider
a
that.
very good cosmesis also by that.
Yes.
But forehead will be too ugly for cosmesis.
I know. If he is willing for a free flap, nothing like it, but you will have to really dissect out good recipient vessels on the next side.
Because
if you have an external carotid and IGV, I think you can do an ALT flap there. That will fill up the cavity also, and it will look nice.
But I think Dushan told that the carotid was ligated in this patient.
Yes,
external carotid is ligated. Then you may have to go to the opposite side. That will be little.
You will have to
long pedicle required.
We have to drag a lot of de-epithelialized skin under the cheek skin in the next side.
Yeah, you may have to open up the remaining skin outside and relatively better access to go to the opposite side.
And put it there.
Yeah, take a very long ALT, de-epithelialize a lot of
Yes.
it to the next skin,
Yes.
and the distal part comes here. I think that will give good contour also, I guess, in the end. So.
Yes, that is the best if patient is willing.
So I have not seen a third case in this series, but there I had done the same thing, but still it dropped down.
No, so that's what I'm saying. You drill hole somewhere and then hitch it to that bone with a Prolene or an stitch. So it may stay and stuff in more, so that cannot drag down, support it over there.
Many times I think that I should give patient head down position for 1 month.
No, the other thing you can do is you can de-epithelialize the ALT flap, take it under the skin of the upper part of the defect,
right,
and then do a transfixation suture. Yeah, do a transfixation suture with Prolene. Because
hitch it to the zygoma. I'm telling you.
Yes, ma'am. The bone support as well as you take some more
and like an extension of fascia into the subcutaneous space.
And then take transfixation sutures and then keep it there for 2 months. What's going to happen?
Right. I think that's a great point that you don't only suture the skin, as Dr. Sandeep also rightly said in his presentation, that the soft tissue around the flap also needs to be sutured in a good way to keep the flap in that place. I think that's a good point which comes out of it. This is a peculiar case. I think it is 8:55, but I think I will take a few cases more if you all are fine with it. This is a young patient in whom.
It's 8:55. So ask the panelists if they want to continue.
Yeah, that's what I'm asking actually.
Yeah, no problem.
No problem. Great. And we have around 100 plus participants still with us. So this is the patient in which we did a fibular resection.
One minute. So, yeah.
Yeah. and there was an outer skin defect also. The patient had some healing issues post-operatively, definitely. The patient went for the radiation also. After radiation, patients started having a kind of a hard palpable thing in the submental area, open the fibula flap. And we were kind of worried about this heart issue. You know, we were thinking that it is plate which is broken, or what it is. You know, it's malignancy coming back, or some node or something. And surprisingly, when I will rather like to ask you people that what this thing can be. You know, this was not malignancy. This was
not plate.
This was not
This was not plate, not malignancy. This must be the bone from the periosteum which you have left behind.
Yeah.
Of the when you strip off the periosteum, some of the periosteum may be hanging down, which has formed the bone.
Yeah.
Or a broken plate. You said it is not plate, it is not malignancy. So the only other thing can be the periosteum.
Yeah, very rightly said, ma'am, that we were dealing with bone formation from the periosteum, which we left on the stripped off pedicle. And though it is not very common, it is not very uncommon also.
We've had one case exactly the same in the max.
We had two patients like that. So that's why
I guess I don't remember this patient.
Yeah.
So I remember the army major.
Yeah.
The maxilla.
Huge. Correct.
His was, I think, 2 or 3 times bigger than, and we had to drill out that bone because he was complaining of cosmetic problems.
Yeah.
Exactly. That is the problem. It's happening here. You know, the issue is that the skin is too thin over it. So if we put an incision and we drill out the bone, I'm just worried that will there be an dehiscence of the skin or not?
It is already telling you from where it wants to come out.
And at the same time, the spur will come out from the skin. It looks like it is stenting the skin.
It's telling you from where it wants to come out.
Yeah. So
go directly on it, hinder that, break it and bring it out.
Rather than it comes out, I should take it out.
No. You must be worried about that. Whatever. The patient is bothered about you, you take it out. Otherwise, when it comes out, you take it out.
Okay, right. So I can even wait and then take it out.
If patient is not bothered.
Yeah. So there was an article, I did a literature search, and we found that there are instances like that where you leave the periosteum. In this article, they did a comparative study of lifting the pedicle with periosteum and lifting the pedicle without periosteum. And in that without periosteum series, there were not bone spurs. And with periosteum, there were 7 patients where they had bone spurs, which grew afterwards. Now the hardware issues, most of the part, Deepak has kind of covered up the hardwares, but we definitely get, this is one which Deepak gave me, and these are the problems which happens to us after radiation. The skin gets out, thins out, and you have hardware which is outside, and at the areas of the screws you have kind of pus coming out. So Deepak, I would like to extend your suggestions in that matter. That can you do something while you are inserting your flap to avoid this kind of situations?
Yeah, the commonest thing you can do is you can utilize part of the skin paddle of the fibula or scapula, whatever you're harvesting, and use it as a second layer over the plate.
Right.
And then just drape it over the plate and suture it down somewhere in the dermis.
Right.
That will give you an extra bulk. I like the scapula that way because scapular skin is slightly thicker, and then you can really play with the skin a little bit more. But de-epithelializing a really thin fibular skin paddle is, you'll end up with a very tiny, thin sheet-like, paper-like layer, which still might be effective. I really don't know, but de-epithelialize and try to tuck some tissue over the plate.
Right. So I think that's a good point, that usually when you are doing this segmental resection, you go very thin on your skin of your cheek flap, and usually that tends over your plate, and especially anteriorly, it tends and stretches, and post radiation you get dehiscence and then plate exposure. So if this type of things happens post-operatively, now say in the first patient where he has already completed his radiation around 1.5 to 2 years down the line, and still this plate is open and exposed, how you will tackle this, Dr. Iyer?
What is this flap?
This is fibula.
Fibula. So I would like to look at the bone, whether it is viable or not. Mostly it looks like viable. It's only the plate exposed. In that case, I would remove the plate, and then the skin, you might need to provide some skin because it's hardly likely to close. So maybe a pedicled supraclavicular or small DP.
Shift the nasolabial.
Yeah. What?
Maybe shift the nasolabial down.
Nasolabial.
I don't know whether it will do.
Yeah, it might not. Yeah, you can do, but the scar is here. So if you bring it down,
I don't know.
Might not. Maybe a supraclavicular or DP type of, small thing which will cover that, and then you can release the pedicle later on. Might be the best sort of thing.
So what happens when you go inside and put an incision on this skin is that the dimension of the defect increases?
Yeah, now your Dushan, the question is, are you going to remove the entire plate or not? I wouldn't, but you see that the plate in front also, the skin is going to dehisce.
Yes, here.
In the chin area.
Yeah.
So I would open up that area and go slightly posteriorly and anteriorly, take the plate from that area. And then be ready to provide the skin. Unless sometimes you find that even the epithelialization has occurred beneath the plate.
Behind the plate. Yes.
Behind the plate, then you leave it. You just leave it like that. Otherwise, you will need to.
Akshay, you would like to add anything, or?
Just looking at these cases, I remember Iyer sir in the OT4 managing all the complex cases. Just a point about reducing the plate exposure. Our plastic surgeon Prashant Puranik sir, what he does is he takes a chimeric muscle, the soleus muscle, and uses it to cover on top of the plate, especially when we are doing subfollicular kind of resections. So that's how he manages, and it becomes a little bulky, and post radiation, the profile of the facial profile fits very nicely because of the muscle cover over the plate.
Akshay, I remember. Hello.
Sir.
Yeah, Akshay, I remember talking to Puranik, and he had presented a case also where he took chimeric soleus to put in the ITF fossa or in the because
yes,
what
he had
in a
we had presented in that in your conference only, a series of cases.
Yeah, right. So basically, when you remove the masseter, you remove all those tissues there, and you put a fibula. The mandible is okay, but there is a kind of a depression in that area, infrazygomatic, and where probably that can help to give you a contour. The only thing I wanted to know whether on a long-term basis, doesn't that muscle also, atrophy?
It atrophies.
It does atrophy, but I think it corrects it, and reasonably the function. I mean, the cosmetic appeal is pretty good. I have just seen patients like last 1.5 years, probably 2-3 years down the line. If you see, you may get a better idea.
Okay.
Yeah. So taking ahead these hardware issues, which plates to use? Mini plates, which thickness, which screws, recon plates, weight bearing, load sharing plates. There is a plethora of choices with you. And we had some hard ones with mini plates also. And there was breakage of mini plates and kind of bad experiences. But I would like to know from Deepak. Deepak, what is your principle? What do you use for your fibulas?
I mean, in Amrita, we always use reconstruction plates. because they are load bearing and they're not load sharing plates. And the issue is not whether it's a recon plate or non-recon plate, but the size of the plate matters. Because right now, for affordable patients, we're using the Stryker low profile 2 mm plates. So they have much lesser, even though the picture that I showed you was the Stryker plate which was exposed.
Right.
I think moving from a 2.5 plate to a 2 plate makes a lot of difference from a plate exposure point of view. And these low profile plates tend not to tent out into the skin and things like that. So I think Amrita policy has always been to use a reconstruction plate and then use a low profile plate if possible. It should be a locking plate with screws. So, but having said that, I've seen a lot of good results of people using CAD CAM and then using multiple mini plates to fix it. And there's always this argument in literature, which is better. They have their advantages and disadvantages, both of them. But our principle has been always to use the reconstruction plate.
Right. Prabha, what about your experience?
See, if the patient can afford a recon plate, because nowadays you get a low profile recon plate with locking screws. The previously used to have a very thick recon plates. That would always get exposed, and then to remove that is an hell of a job if it gets exposed.
Okay.
So that is, now you get a very low profile recon plate which you can use. Otherwise, mini plates are good enough because you don't really move them, but sometimes these mini plates do fracture. That's depends on the company, what company. Sometimes you use the plates and screws. Sometimes they fracture and then you have a problem. That is there. But otherwise, mini plates we use quite a lot. Mini plates, at least in Tata, because money constraint used to be there. So the mini plates will cost little less than a recon plate.
Okay.
But given a choice, a low profile recon plate with locking screws.
So I remember that when we had few issues with mini plates like fracture, etc., we went to the company, and when we asked their experts, they said that these plates are not for your not for this role. They are for the small facial fractures where the bone segment is pretty stable. So I think that makes a lot of sense not to use these plates, and wherever possible use low profile reconstruction plates. So one more thing is that when you use this fibula flaps, when you start your mouth opening exercises, do you do it aggressively? Do you ask patient to chew everything? They do active exercise kind of therabite or orabite? Or if yes, when? If no, till what time they should not do any mouth opening exercise? Because post-operative trismus is also a big problem in these patients. Amit, I would like to ask you that what is your protocol for this fibula patients, mouth opening exercises?
Once the wound heals, most of these patients we put into, means not the aggressive mouth opening, but chewing, we start on chewing. But terabyte, we are not, most of the patients who can afford, then we prefer to give terabyte. But at least for around, when the wound heals till around 6 weeks, after 6 weeks, then we tell them to do stretching exercises.
So 6 weeks is you don't load 6 weeks.
And in those patients only in which we have manipulated the mesenteric spaces.
Yeah. Soumya, your practice?
Again, when wound healing is, I think from first visit to the OPD onwards, we start counseling them, or we send them to the speech therapist. Those are the people who teach them, the occupational therapist who teach them to use the key which is given for mouth opening. And as and when the patient gets comfortable, the pain reduces, they are a little more comfortable with things, they start using it. We do not restrict them that till this particular day you're not supposed to do mouth opening exercise or any such sort.
Okay. Deepak, what about Amrita protocol?
I mean, we give the mouth opening exercises as a prophylaxis for radiation, I think, considering the radiation is what's going to cause the trismus. So I would probably wait for 6 weeks, because by 6 weeks the bones also will start to unite, and I think 6 weeks would be an ideal time. We don't
So,
have any routine practice like that. It's only for the radiation we start to give.
so it's kind of an just an physiological mouth opening, or you use some devices, or you allow use of
No,
devices.
if it's during radiation and we know that the patient is going to have impending trismus, then you use an appliance to keep the mouth open. That is fine.
Okay.
But prior to that, they'll be on a soft diet, and you slowly upgrade the soft diet to a semi-solid diet over a course of few weeks. But then the terabyte begins after that.
If you have, there was a trismus before surgery, and if you have forcibly opened the mouth on table, I think the patient needs to start exercises maybe about 2 to 3 weeks after surgery, because fibula will heal like a fractured mandible.
Yes,
So the fractured mandible usually heal within 3 weeks time. So you can start those exercises, whatever physiologically he can open, let him open and try and open. And then he starts after 2 to 3 weeks, he starts the jaw stretching exercises, he has an adequate dentition behind. Because if you start just before radiation, nothing is going to work, because by that time what you have torn open will again become much fibrosed and it will be too tight a mouth. Post RT, so you don't expect them to open afterwards, because RT is a bad period for them to do too much exercise. So before they go for RT, I think they should have a good mouth opening, what they should maintain it through the radiation. That's my philosophy.
So I think a great point, because many reconstructive surgeons are kind of worried about their plates and bonds and everything.
No.
Delay the mouth opening exercises, which is actually wrong, which will actually deny the patient the mouth opening which fibula will give them. So it is better to start them early.
In fact, I tell them that you need to do it every hour, 5 to 6 times throughout the day. Only in sleep they will not do it. That's the only thing.
Okay.
Then only it will open.
A great deal of mouth opening has to do with reinforcement of the idea, the extensive counseling that madam gives each patient, and whom, what we have actually started repeating what she used to tell patients, that even when you're sitting outside my OPD, you should have that key in your pocket and, you should be continuously doing the exercise. That constant reinforcement each time an OPD visit happens should occur.
I think that's a great point. Even in our oral cavity panel, there was unanimous voice that post-operatively mouth opening exercise are very important. Start as early as possible and do it aggressively. And everybody needs to remember this. The next case, I think, must be the last. Is the patient with vitiligo. Somehow, I don't know, I have bad luck with vitiligo patients, or everybody has it. But this was the patient where we had a lip defect and there was a dysplastic mucosa at upper lip. We did a small STG for it and a nasolabial for the lower lip. And I don't have the pictures of the necrosis, but on the 4th or 5th day, the distal tip of the flap started necrosing. And we had a bad defect. Patient didn't want to do anything else, and the patient went home. But that was not the end of the story. The same patient came to me with a bad left buccal mucosa recurrence. Now I didn't have any choice. I had to do an ALT flap, a bilobe ALT. On the 3rd or 4th day, the inner pedal was fine. The outer pedal started necrosing at the periphery. And so the surrounding skin also started having inflammation and all around it. This is not the only case I have. In all the vitiligo patients, we had some point of problem at healing problems or vessel problems or kind of partial necrosis of flap and everything. So I would like to ask the panel that with this patients with autoimmune disease or vitiligo or SLE, do you find some problems in healing or flaps? Subbu sir.
Vitiligo, so far, no. SLE, yes.
SLE, yes.
And then those are the things mainly. Vasculitis can lead to, so you have to be careful. Vitiligo, if I remember correctly, nothing has been so badly. I don't know whether I can't comment because it has not visited me.
Okay. Anybody else will like to give any suggestions?
Suggestion regarding?
Or any other experience they have with vitiligo or SLE?
SLE,
Yes.
you can expect a problem, so try and avoid. But vitiligo, we have done few cases. We didn't have any problem.
Okay. So I think we will take some last cases where you find that there is a flap which will kind of meet your need, and it immediately may meet your need also, but down the line you find that you were aiming for a full pant and you are having a half pant in your hands. So these are the cases where even Deepak shared with me. I think this is a patient where there was a fibula and there was a bulk of flap also was required, but one flap was done and it seems like it was not enough. In this case, it was a good defect. We did a marginal mandibulectomy, and the flap which we placed that, just vanished off after some time of radiation. Again, here is an maxilla patient where an LT was done, and it looks to us that we did good initially, but down the line we were not able to give the optimum result to the patient. In this type of scenarios, kind of single flap is not fine, or the flap doesn't behave good afterwards, radiation, or it doesn't give a good contour, good cosmesis, good function. Any suggestions? Do we do 2 flaps in these patients? How to tackle this situation? Soumya?
So, irrespective of how well we have planned preoperatively and intraoperatively, what radiation does to these flaps is quite unpredictable most of the times. What type of radiation these patients receive also, at least in our practice, we can't determine it, because for radiotherapy, the patient usually goes back to their hometown. They can get anything from a cobalt to a well studied IMRT radiation that these patients get. So, of course, we need to look at the defect in a 3-dimensional manner, and not just the mucosal defect and the skin defect, but also look at the soft tissue deficit that's there and plan accordingly. And that's what you can do. And but even then, sometimes you do encounter these unfortunate situations. And of course, you need to be honest with the patient and have a conversation with them about how willing they are for a second surgery to change this contour deformity. Send these patients to your prosthetic department to see if they can help them in some way. If not, in male patients at least, we have done scalp flaps where the donor site is hidden, and the hair bearing area, they sort of cover it up by growing a beard, and a lot of patients have been very happy with that outcome. But yes, it's a difficult problem is what it is.
Dr. Iyer, you would like to add something?
I would always look at the soft tissue, like Sandeep was saying about the initially, that we all concentrate on the bone, but we pay little attention to the soft tissue requirement, which is very pertinent. Now, if you want to do a double flap, you have to do it. You cannot stretch a single flap to go this way and that way and give you the best contour. So there, if you want to have a good result, you have to have a less threshold for second flap. The second flap need not be a free flap, need not be. When we started, we published also a large series of double free flaps, and then future and V series, and huge. But of late, our second free flap is either DP flap or a supraclavicular flap, which gives a much better, color match to the face. So need not be second free flap. You pectoralis major, DP or supraclavicular will fill in that role of a second free flap. But I'm not saying that second free flap should not be done. It should be done in certain cases where radial forearm with a or ALT with a fibula, or radial forearm with ALT, fibula is good. But don't mince your Don't be stingy in your soft tissue. That is the reason why you end up with this defect.
See, wherever there is a third dimension that comes in,
Correct. Yeah.
the fibula can never fill up that third dimension, which goes to the like masseter and muscles and everything. So that third dimension, your second flap has to come.
Correct.
I mean, you need to calculate as you go laterally, your third dimension goes on increasing.
Yeah.
So if that flap is not able to is adequate, then maybe, but you should take that decision well in advance during the surgery that you require a second flap. You don't start it at the end of the surgery. My God, now I require to go second.
Correct.
I think
so that decision can be taken early in the morning when you're doing the first flap.
So I think it is in the planning phase that you see the habitus of the patient. Some patients have very thin lower limb, and you're actually overstretching your limits while you are doing this kind of reconstruction. So you need to plan, and you need to in advance counsel the patient also about the need.
And that is the best time to do it because the neck is virgin. You have all the vessels. Now to go after post RT and the operative site, then it is little more riskier than when you do it per primary when the whole neck is open and all fresh vessels are there.
Right, sir. Nitin, Ashay, we have questions?
No, sir. Almost all questions are answered during our discussion.
Great. We had
any open question.
Who is kind of 9:22 and still on, and so I think it was a great discussion, great panel, and a lot of take-home messages.
Can I say one thing?
Yes.
I don't know how everybody does the monitoring of flap, but our standard is an prick method that you see the bleed. Whether you do a Doppler, the Doppler signal is there or not, I will prick the flap and see the bleed.
And you will scratch it or prick it?
Scratch it or I'll prick it. Okay. Because scratch may leave a little bigger scar. If the prick doesn't give me bleed, then I'm worried, then I'll scratch it. But I'll do one on table, that's my baseline.
Right.
So that is whether it is bright red fast, it is bright red slow, so you can compare it post-operatively. Otherwise, suddenly one person has seen it in on table and one seen it afterwards, and he says, no, it's very slow, then you get worried sitting at home that something has gone wrong. So that thing one need to mention.
Ma'am,
and the neck position. What neck position you want, what not to, that's very important.
Right.
Sir, can I ask one question, sir, to ma'am, sir?
Yes, please.
Yeah, ma'am, how many days you are going to do this method, the prick method?
48 hours. No, about 40. See, first 48 hours is important. After that, I expect less problems. So then my vigilance reduces. Then it may be twice a day or thrice a day, not more than that.
I see
no maximum problems will happen in 48 hours.
Yes, ma'am. I seen on third day, I don't want to do a prick because I seen a hair on that side. So
yeah, that is one way of you're seeing a growth. That's good. So that means the flap is viable. No? Otherwise, the hair will not grow. That's fine.
Right. So I think the clinical judgment of flaps color, turgor, and your screen sketch is the best gold standard right now. Whatever else you have, kind of Doppler or sonography or whatever fancy devices you have, substantiate your clinical judgment, but it is not something on which you can rely on. So that's the take-home message. The entire discussion and the entire concept is to discuss your complications and come out. You know why we have kept this 6 series on 6 as complication, because we are kind of living in our own world. We don't want to confront our complications, or we don't want to discuss our complications. And I will say that this discussions and confrontation is a great learning tool.
Dushyant, sir.
Yeah.
Can I ask one question?
Yes, why not?
To Prabha ma'am, does we have anything like delayed bleeding? While scratching the flap, if you see there is a delayed bleeding.
Yeah,
is there any concept?
No. See, it is how fast the bleeding comes. Sometimes we feel that you scratch it, now you go see other patient, then the bleeding will come. It's like that. So sometimes it is slow. So that's why I'm saying on table when you prick it, that's the first prick of the day. So that you monitor and it should be comparable to that bleeding. There are such few flaps, sometimes they don't immediately bleed. They take their own sweet time to have the small bright red, but it is bright red that comes. It does happen sometimes, not routinely. But then you get a little worried that there is no bleed. So if when you see a flap where there are multiple scratches on the flap or the pricks, that means there is always a doubt that something is not right with the flap. When you see so many scratches on the flap, you are not getting the bleed. So then you need to be a little careful in seeing that patient.
And I think you need to be careful in scratching and pricking it repeatedly also, because it causes subdermal hematoma and
Yes.
gives false impression.
So try to do it at the a little closer to the margin.
Right.
Don't go bang in it.
Right.
Any tips to monitor the radial tube flap for circumferential hypopharyngeal defect? Any tips from the panelists?
If you can bring out a monitoring paddle into the neck skin, desirable. But if you can't, then it is very difficult to see that unless you see the neck drain or the reaction of the skin on the neck skin. But by the time you detect that if something dead is there, the skin will become inflamed or indurated. By the time it is late to salvage. So I would like to bring out a paddle of skin outside into the neck skin at the lower end, where you need to deepithelize, but you need to take into account the deepithelialized segment, or you can divide it, a segment of it, and bring it out. Otherwise, the deepithelial segment can pull that your inner suture line and cause an OCO, a leak over there. So that you need to be careful. But that is, I'll comfortable if I can bring it out and monitor it.
We had kind of a implantable Doppler device with us for some time.
Yeah, if you have that, that is fine. But if you don't have it,
but I will rather like to tell that we had bad experience with that Doppler device.
Oh.
The sleeve of the Doppler device, which goes on that vessel, in 3 of my flaps, it kinked the vessel. So the flap died because of Doppler rather than otherwise. So in those buried flap, I started that using Doppler. We did around 25 cases, but then because of this reason, we stopped using that Doppler. So now
I've actually used the Cook's color Doppler, the Cook's Doppler, implantable Doppler during fellowship. We never had the problem with it compressing the vessel. Maybe I don't know.
And one thing about the pedicle, when it is too long or too circuitous, we said that we will stitch it somewhere or clip it somewhere. But sometimes that spot itself becomes like a spot for the case. Yeah. So what I do is nowadays I lay the vessel how I want it, then put and cut out of our glove on it, and put a saline gauze piece over it, and put the skin over it. Do the rest of the some work. By the time you come back, you take out the gauze piece and your thing gets glued to the bed. So it is one type of ironing that you don't have to then fix it by any stitch or any clip. I mean, in Korea or somewhere they spray fabric glue spray so that the thing stays in one place. So this is one way of doing that. You put it in position that you want, put an glove, cut out glove, and put a wet gauze piece. So because if you don't put a glove, while removing the gauze piece, you will again dislodge that position what you have. So that really works very well.
Right. We sometimes surgical over it. Surgical or kind of a small sleeve of surgical.
Yes, yes. You can lay down a full surgical over it over the bed. That makes it stick very well.
Yeah. So thank you everybody. It was a great panel, great discussions, and great take-home messages. I thank entire panel for staying for such late, and still we have a good number of participants who are also very much active on the chat box and interestingly listening to all of us. I welcome you all to our next session, that is the last and final session on salivary glands and ORN, that will be on the 15th of August, the Independence Day. And we have Dr. Jatin Shah, Dr. Kuriakos, Abhishek Vaidya, Alok Thakkar, Dr. Jyoti Dabolkar, Dr. Kinjal Jani, Rajesh Kantharia, Saurav Dutta, and Vikram Kekatpure for that final panel. So thanks again, everybody. And it was a great day. This entire series is available on the website also. where all the recording of all the sessions till now are there, and they will remain there. So you can go back there and refresh if you want. Thank you all and good night.
Good night, all of you. Take care.
Congratulations, Dushyant, for doing this.
Thank you.
Very good.
Well done.
Very good initiative.
Well done.
Thank you so